I
YouTube
understand.
is
Okay.
affected.
I'm gonna mute myself because I have trouble not talking.
Okay, I will start shortly. YouTube is affected.
I'm gonna mute myself because I have trouble not talking.
So good morning, everyone. Welcome to the sixth annual Chicago Sickle Cell Summit, titled Thriving with Sickle Cell Disease, Optimizing Care Through All Ages. We welcome you all to this summit, and also would like to thank everyone that was responsible on part of planning and organizing the summit, especially all the organizations listed here and individuals. So I'm going to give some housekeeping details. We are streaming this video summit, and also we will be having the videos online and recording it. So for privacy issues, your microphones as attendees will be muted. If you have any comments or resources you would like to share with everyone in attendance, please put it in the chat box. Our Q&As is open for you to type in your questions so that the moderators will see them quickly and respond to questions. So like I mentioned earlier, this summit is being recorded, and we will definitely have it on social media. If you have anything you want to tag us, please use the hashtag Chicago 2023 SC Summit, so that everything related to the summit will be stored there in social media. Also, this summit is an educational summit, and if you have any questions related to health, please consult your doctor. This is, like I mentioned earlier, this summit will be photographed, and so attending means that your images and voice is going to be part of the recording. We do have continuing education credits for providers, residents, nurses, and social workers. If you want to be acknowledged or to receive those credits, please make sure you are using your unique Zoom link so that we will record your attendance. And please contact Judy Norsek if you have any questions. I think we're not able to get that for the College of Pharmacy, but join the headcount by SNAPA. And so we have a full agenda today, and hopefully we'll get through all these wonderful talks and topics and conversations. We have three main sessions. We have the genetics and foundation of care for sickle cell disease. We have emerging care, medicine, and treatments. And the third session will be building community relations and partnerships. So I will start by introducing Dr. Sue, who will be giving an opening remarks.
Thank you, Beverly. So my name is Louis Sue. I'm a pediatric hematologist, and extremely pleased to co-host this whole meeting. I think that this is the 6th Chicago Sickle Cell Summit, and this is a unique conference which has been basically planned by stakeholders, by the individuals living with sickle cell disease. It's taken over half a year of planning, probably close to a year of planning, paperwork, as you heard, but all the details we're hoping will come together with the magic of Zoom. We welcome everybody's participation, and the three main sections of this of this conference are first, session one, the genetics and foundations of care. Second is emerging care, medications and treatments. That'll be after a lunch break. And then the final and premier part of this will be community links panel discussion. And we hope to conclude at about 3 o'clock. This is brought to you by, as you saw in the first slide, multiple institutions working in collaboration. And much of the theme of this conference is how much is going on in the whole Chicago region, that it's not just like one place. And we have also Dr. Wanda Whitten-Shurney from Michigan to share with us, how much there's regional and national spread of knowledge, and everybody is working together to advance the causes in sickle cell. I'm going to turn over to Ms. Bridget Reynolds, see if you have additional comments. Welcomes.
Thank you. Good morning. Well, I'm going to go over some CAB updates. Again, my name is Bridget Reynolds, and I am a member of the UIC Isaac CAB. And I first want to talk about what the advisory board is about. The Community Advisory Board of Isaac at UIC Chicago is comprised of persons with sickle cell who are actively advocating within the community, and we have persons who are determined to bring about change, positive change for people with sickle cell. UIC Isaac partners with multiple health systems such as Sinai, Holy Cross, Lawndale, UI Peoria, and we seek to expand partnerships with neighboring health systems and providers. Next slide, please. Who we are. We are UIC Chicago and partner sites. Members of our CAB are, our coordinator is Judy Nosek, PhD, Ryan Cameron, who is a research coordinator, Maxine Banks at Peoria, Beverly Chukwuadzi, Patricia Lacey, project coordinator at Mount Sinai, Chicago, Dennis McCullum, linkage coordinator, Dorinda Lawrence Sims, and Bridget Reynolds. We are made up of people of various backgrounds and talents. Next slide, please. Our mission aligns with that of Isaac. We aim to improve care design. We aim to aid in improving care design and the life satisfaction and experiences of people with sickle cell within the community. And we are the boots of the ground. We aim to be present in virtual and physical spaces and to keep abreast with our experiences and healthcare needs and the social and economic demographic. Next slide, please. Our process, what we do, well, we monitor, we report, and we address. We assess the current climate, we report and address the needs of our community. We draft position papers, we present updates in national research meetings. We attend weekly Isaac Isaac meetings and other advocacy boards and/or panels. We lobby Congress, we attend hearings, advocacy days like Rare Patient Disease Day, and we work with community-based organizations. We organize and present the annual summit, what you're in now, and we network to expand our reach. We expand the knowledge base and competency of the research team, as well as those providers that we seek to bring aboard with us. And we improve how patient advocacy boards operate. Next slide, please. Now, CAB participation. To be part of a CAB, it involves 3 elements. And first of all, members of a CAB need to be foundational with that project or that research study. We need to be at the very beginning of that study or the research, because you need to know exactly what it is the CAB members are going to need. And we want to be a forethought and not an afterthought. And for example, budgeting concerns or whatever the needs are of the CAB members, so that we can do what we need to do, and to get a flavor of how valuable CAB members can be to that research, how we can inform the direction of that research. And we need to have the access to the networking or some of the places and spaces that our PIs are part of. Not every part of it, but a lot of that so that we can be a face to those connections as well. And they get firsthand experience. So, and we also need to reap the benefits of our labor. Now, what do we do? What do we bring about when we become a member of a CAB? How do we affect this process? What we want to do is, first of all, we build trust, we contribute and partner in change and solutions that provide real life experience, real life perspectives, so that we can share real life experiences to keep that research relevant to people with SCD, sickle cell disease. And so we need a seat at the table, and we need to be empowered, because there is a lot that people who are working in CABs can actually do. And a lot of times people don't really understand that until they start working with the members of the CAB. We come from different spaces, we have various talents. Next slide, please. Okay, I think that's the last slide. So thank you so much for your time. And we're going to turn over to Dennis now. We should be turning that over to Dennis.
Are we getting Dennis?
We don't have Dennis here.
Okay. So I'm going to introduce the first section of our presentations will be life stages and sickle cell disease, presented by Dr. Kay Saving and Dr. Marwah Farooqui. Dr. Kay Saving is professor in pediatric hematology oncology at University of Illinois at Peoria. Dr. Marwah Farooqui is assistant professor, associate professor of hematology. I think it just promoted her at University of Illinois as one of the many adult sickle cell providers. So getting the two perspectives on life ages. Dr. Saving.
Yes, thank you. I think Beverly's going to run my slides for me. Beverly.
Yes, I will run you slides.
I'm having difficulty seeing. Great. Perfect. Thank you, Beverly. So I'm here to talk about sickle cell disease in children. Next slide. I do not have any disclosures today. Next slide. This is just a brief outline of what I'm going to cover, and I will go through things quickly and just sort of do some superficial talking about these different aspects. Next slide. This is a classic slide showing you what the basic pathophysiology is for sickle cell disease. And in the upper right, you see a normal blood vessel with normal red blood cells in it, and they're flowing very freely through the vessel. That's because in the little cut-in inset, you can see the normal hemoglobin molecules floating around inside the red blood cell, and they're not sticking to one another. On the bottom right, it shows what happens with abnormal sickled red blood cells and how they block the blood vessel, not allowing the blood to flow to the organs and tissues, causing hypoxia and chronic and acute damage. As you see in the little inset at the bottom, what happens in sickle cell disease is because the hemoglobin molecules are different, they stick together and they form these long strands that then make the cell take on the sickle shape. So this is the basic pathophysiology that we're talking about in sickle cell disease. Next slide. This slide is a bit more complex, and I'm not going to go through all the detail on this particular slide, but I just wanted to emphasize that there's more than just meets the eye in sickle cell disease. As you see in A, you have the sickle cell molecules sticking together and making the long chains that causes the polymerization. Then in B, to the right, you have the actual sickling of the cell, which causes a vaso-occlusion. But there's also other things going on. If you look to the left, upper left, you see hemolysis. So when the cell sickles, then it's going to break down much more easily than normal. And when it does that, it releases a whole bunch of substances that cause the inside of the blood vessels to not function well. And that's what endothelial dysfunction is. And then at the bottom, it also contributes to what we call sterile inflammation, so that other substances are reduced, are produced in the body and released that cause an inflammatory inflammation in the body that continues all the time, so that at any point in time in a patient with sickle cell disease, all these things are going on at the same time. And we only see them present for care, or they only get significantly ill if there's some other kind of trigger that is added into this constant abnormal state, a trigger such as infection, hypoxia, or something else. Next slide. And that's what it says on the bottom right. Go to the next slide. This is just a refresher to remind us that depending on what type of sickle cell disease you have, your disease may be more severe or less severe. So patients who have SS disease or S beta 0 thal have more severe clinical disease. Patients who have S beta plus thal or SC have less clinically severe disease. Part of the reason for that is if you have thalassemia, for instance, you have higher hemoglobin F values, and that may help modify your disease severity. Next slide. This is just a summary slide showing that every body system is affected by sickle cell disease, really from head to toe. And obviously, I'm not going to go through this in any detail today, but just to remind us of a few differences between children and adults. If you look at the yellow highlights, those are the acute complications that occur in patients with sickle cell disease, and they can occur at any age. If you look at the green, those are chronic complications, which can occur in children, but build up and occur more in adult patients with sickle cell disease. The stars designate things that can be very severe and cause a lot of morbidity and mortality in patients with sickle cell disease. A couple of those in the upper left, meningitis, in the right middle, septicemia, and the bottom left, osteomyelitis. Those are infectious complications that can occur again at any age, but often occur in childhood and can be quite severe. The immune system in children is not mature yet in any child, so it's not as good treating infections as when you're older. That's why in pediatric patients with sickle cell disease, we do some extra things to help prevent infection in those patients, such as giving them prophylactic penicillin until age 5, making sure they have all the regular immunizations, giving a few immunizations early, and giving extra immunizations for a certain kind of bacteria, pneumococcus, which can be a particular problem for patients with sickle cell disease. I've circled in red the acute pain event, which is sort of the hallmark complication of sickle cell disease, and I'll talk about that in a few slides. Next slide. This is a slide sort of summarizing treatment for acute pain episodes in patients with sickle cell disease, particularly children. The most important thing is to try to prevent the episodes. And we do that with education to the parent and then the child also when they're old enough about things that you can do at home to prevent. So giving a lot of oral fluids, get used to taking lots of water every day, avoid temperature extremes like very hot or very cold, and practice healthy living. Try to eat healthy foods, do mild to moderate amount of appropriate exercise, and particularly develop good sleep habits so that you're getting adequate sleep. And then there also are now disease-modifying treatments that we can initiate in patients, and those will be discussed later today. For home treatment, once a patient has an episode, we teach the family to give increased oral fluids. Warmth is very good. No ice packs, but a heating pad, a warm bath, oral pain medications, starting with Tylenol and ibuprofen, and then other things such as distraction, relaxation techniques. Some families use massage, other kinds of complementary therapies that can be very helpful. In children, they usually have pain in the long bones. They can have diffuse back or chest pain and pain over the liver area if they have some involvement of their liver in the vaso-occlusive crisis. Adults have often more diffuse pain, specified sometimes in the back, the shoulders, the sternum. Infants and toddlers have a specific presentation called dactylitis, which I'll talk about in another slide. On the bottom, I've got a couple tough issues, which we do see more in adults. We don't have great pain medicines, so we use what we have, but they're not ideal, and we could use some additional ones that would treat pain better. But adults have some additional issues that are listed on the bottom. Next slide. So how do we manage the patient if the pain is so bad that they need to come to the hospital? Well, as providers, the most important thing for us to remember is that we should always believe the patient. The gold standard of pain assessment is what the patient, or in the case of young children, the family's report is of the pain. We need to believe what they say is the level of pain and where the pain is located. Things such as blood pressure, heart rate, or number of sickle cells seen on a blood smear have nothing to do with the acute pain of the patient. They're not a surrogate marker for pain, and that's very important for providers to know. The key is to do rapid assessment of the pain, treat it rapidly, and then do frequent reassessments so that you can continue treating the pain with appropriate medication until the pain is gone. Pain scales are very good, but I find them most helpful to help rate the pain level in response to treatment, not necessarily what the absolute level is. So if I treat the pain and the pain level goes down some by the scoring, I think that I'm doing the right thing, and I will continue doing that. Later, pain will be talked about in more detail, and individualized pain plans and patient-controlled analgesia will be mentioned. And those are things that can be very, very helpful in controlling pain in sickle cell disease. In general, in pediatric patients, we don't give oxygen or transfusions for uncomplicated vaso-occlusive crisis. We may give oxygen if the patient's oxygen level when they come in is much lower than what they are at baseline, but we generally do not do those things. Literature has shown for a number of years that day hospitals and infusion centers really improve pain control, and they help the patient get rid of the pain more quickly so that it decreases lengthy ED stays and admissions. Next slide. This is a picture of the dactylitis that occurs in the young child. So this happens in generally patients most commonly with SS disease between 6 months and 2 to 3 years of age. And the picture on the right shows what happens. They get vasoocclusion of the small vessels of the hands and feet. And so they get very much swelling of the hands and feet. So their fingers look like little sausages. It's very, very painful for them, and they get very irritable. The treatment is IV fluids and IV pain medicines if they are so severe to come in the hospital. But often, if the parents are well educated about it and note that early, then they can start increased oral fluids at home and oral pain medicines at home and avoid a hospital stay. If the child, however, has a fever because they're at increased risk for not being able to fight infections well, then that is a medical emergency and they need to come right away to be seen. So again, early education to the family is very critical here. Next slide. I mentioned earlier that there are these complementary types of therapies. These are things that can be done in addition to fluids and pain medications, and I've listed some of them on the left. On the right, it just says that there's more evidence for these now in adults, but there's evidence coming up in children also that they can be very helpful. So these are things to remember to be part of the treatment plan for both children and adults. Next slide. Splenic sequestration. This is something that historically occurs pretty much exclusively in children and adolescents. Very rarely could occur in an adult patient. It's most common in patients with sickle cell disease who are small, under 2 to 3 years of age, but it can occur in older children who have SC or S-beta thal disease because they still have splenic function that has usually been lost by age 2 to 3 in patients with SS disease. We have noted that since we're now using hydroxyurea in a lot of patients, some of the splenic function in the patients with SS disease is remaining for a longer period of time, and some of them are having this a little bit older than they used to. what happens is that very suddenly large amounts of blood become trapped in the spleen, and it becomes very, very large. In the picture on the right with the hatching and the outline of something on the child's belly, that's the spleen that normally you couldn't outline it or feel it at all. And it's very, very large and very, very painful to this child. This really can be very severe and is a medical emergency. So the patient needs to be seen right away. And again, early education to the parents is key. So they recognize that if the baby or small child has a tender, swollen, hard belly, they need to bring the child in right away to be seen. And the treatment is hospital admission, IV fluids, and cautious transfusions. Very frequently after the child is all recovered, they're home, they're well, an outpatient splenectomy can be scheduled for the child so that they don't have it recur, but that's an individualized decision with each patient. Next slide. Go ahead and hit the button, I think, for that. So this is a slide talking about acute chest syndrome, and acute chest syndrome can occur in children or adults. And the diagnosis is made by someone presenting with fever and or new respiratory symptoms like a increased respiratory rate, findings that are abnormal when you listen to the lungs, and the presence of a new pulmonary infiltrate on chest x-ray. So on this slide on the upper right is a normal chest x-ray, and you can see a clear difference on the one on the bottom right where you have a lot of white fluffy stuff on either side of the heart. It's not a clear outline to the heart. This is someone that has acute chest syndrome. And a few things to remember about children. Often when they present with acute chest syndrome, at the beginning, they don't look very sick, and they may be sitting there very comfortable, have a mild fever, maybe just a little bit faster respiratory rate, but within a couple of days, they can be quite ill. So we err on the side of being conservative, and if we suspect the child has acute chest syndrome, we will admit them for close observation and for care. In children, it's often sparked by a viral or bacterial infection, but they don't have to have an infection to get it. And it's often goes with or is followed closely in tune with a vaso-occlusive crisis. That's more common in the older child. But because it can either be infection or infarction or vaso-occlusion or both, we treat as both. So we give IV fluids and pain medicines as well as antibiotics. And we can't tell on when the child first comes in how severe they're going to be, so we treat them all fairly aggressively. Next slide. Next slide. I did say on this one at the end that after they're all recovered, if they weren't on hydroxyurea, it's very important to start them on that because it can help prevent that. This is a slide that just sort of is a cartoon showing you the different kinds of things that can happen within the central nervous system to patients with sickle cell disease. And we're not going to go through all of these. If you look at the right side, this lists the most common things that we see. Fortunately, they don't happen, the strokes don't happen extremely commonly, but we do see them and we need to know about them and educate families about them. Children more commonly have what's called an ischemic stroke where the blood vessels are blocked off and then the tissue beyond that blockage gets hypoxic. Hemorrhagic strokes are more common in adults where they have actual bleeding in the brain. But then something that's much more common are what we call silent strokes, small areas in the brain where there's been a little tiny stroke so that you wouldn't note it externally. The patient doesn't have a seizure, or they don't lose loss of motor function on one side of their body usually, but they have other problems. And in children, that usually manifests as cognitive defects, meaning they have some trouble in school, or they may be very hyperactive and can't control what they're doing in the classroom or at home and be diagnosed with ADHD. So it's just important to know that these things can happen in sickle cell disease, and it's something else that we educate patients about. One of the great improvements we've had in treatment of children with sickle cell disease is there's now a study that we can do. It's a sonogram study called a transcranial Doppler, which we do starting at age 2 annually on children, where we can use that to assess if they're at an increased risk of stroke. And if they are, then we can do things such as blood transfusions monthly or hydroxyurea daily for them to reduce the risk of a stroke. Next slide. Priapism, I wanted to mention this. Obviously, it occurs only in little boys, but it's caused by, again, sickling and the vaso-occlusion of penile venous drainage. And so parents, again, need to be well educated about this because it can often be treated at home, but they have to be aware that if it doesn't get better at home, they need to bring the child into the emergency room. So we generally tell the parents that make sure that you are checking the child to see if there is penile erection that doesn't go away. If that's the case, start the home treatment, which is lots of home IV fluids, pain medicines at home, warm packs, or putting the child in a warm bathtub of water. Try to get them to urinate, and a lot of times in a small child or a even bigger child, just let them urinate in the bathtub. Some teenagers have told me that doing some exercise, like some slow jumping jacks or walking in place, doing some form of mild exercise also helps. But if they're still having the problem at 2 hours, we say you need to consider coming to the emergency room, give us a call, or go straight to the emergency department so that they can give IV fluids and pain medicines. If it doesn't get better, sometimes blood transfusions are given, and then there are other surgical things that a urologist can do if it does continue. So again, it's very important that the parents know about this at a young age, and the child, as soon as they are a bit older to understand, also knows so they can report that to their parent if it occurs. Next slide. So kind of summarizing medical treatment for children with sickle cell disease, the key: avoid extreme temperatures, get used to drinking lots of fluids, give lots of education to the family and the child. And we can only do this because now we do newborn screening. So we know at the time a child is born if they have sickle cell disease, and we do lots of education in that first year. We have pain medications and complementary therapies that were mentioned, and specific therapy for different complications. Then I did mention earlier prophylactic penicillin, very important to age 5, and vaccinations that we give that are, again, very important. We follow this very carefully in our patients. And then there are a number of preventative kinds of things that we recommend. Start dental exams when you get your first teeth. Somewhere between 1 and 2 years of age, start your annual dental exams. We start annual eye exams at about 8 years of age, just looking for any changes in the retina that could occur with sickle cell disease, not usually seen till later and not that common, but can occur. I talked about the transcranial Doppler helping us reduce stroke by finding children that have increased stroke risk, and we start doing that annually at age 2. There are renal and other kinds of screenings that are also done. And then other things that we do are red blood cell transfusions. So we want to make sure at a very young age, preferably before 1 year of age, before the child's had a transfusion, that we look at their red blood cells in a special way in the lab so that we're able to match them very closely with other blood units that they might need later on if they need a transfusion. And then others today will talk about disease modifying agents and the other therapies that are now available. Next slide. So survival, there's a lot of good news about survival in pediatric sickle cell disease. In the United States, over 95% of children survive into adulthood. And this is due to things that I've mentioned: newborn screening, the antibiotics, immunizations, transcranial Doppler screening, disease modifying therapy, and improved understanding of the disease in those early slides that I showed, which has helped us make these disease modifying therapies. But overall, the news is not so rosy because the median survival is still in the mid-40s to 50s, and it really has not improved significantly in the last 20 years. Next slide. So how do we go from surviving to thriving? This is an article you might want to look at from 2019. It just looked at a lot of data, statewide data from across the United States, looking at how well are we doing with these things that we know helps children with sickle cell disease have better lives and thrive. And they found that really only 18% of children were receiving the prophylactic penicillin as directed. More than a quarter of the children were not getting their pneumococcal immunizations as they should. They weren't getting the TCD screenings. And so they recommended the 4 things at the bottom. These are things that we could do to help the child move from just surviving to thriving. Next slide. So I've listed at the bottom in red additional things that we emphasize to our families. healthy living that I mentioned earlier, including working on the social determinants of health, and improved early life access to care, both with primary care physicians and hematology providers who will help them optimally transition to adult care. Next slide. So I want to thank all the sponsors of and the participants in the summit, the Chicago and Peoria Sickle Cell Care teams, and most importantly, all of the patients and families that we have. The bottom right shows our bridge in Peoria that we light up every year in honor of a sickle cell month in September. Next slide. So I'll entertain questions now, or they may come later. That's up to Beverly, come later with the panel. Thank you very much for your attention.
Thank you. Dr. Farooqui, do you want me to run your slides?
Yes, please.
Okay.
All right. Thank you, Dr. Saving, for making most of my job easy for the next 15 minutes. A lot of what you said, I'm going to just add a little bit to it. I'm Marwah Farooqui. I am an adult hematologist over at the University of Illinois, and I'm going to go through the various life stages of sickle cell disease, from thriving during childhood to springing into adulthood and hopefully aging gracefully for our patients. Next slide, please. I have no disclosures. Next slide. So as Dr. Saving had mentioned, overall, the lifespan for patients with sickle cell disease has increased in the last couple of decades. However, we still continue to have the average life expectancy around 40 to 50 years of age. This is very disheartening as an adult hemonc physician to me. In addition to that, we lose significant amount of young adults in the third decade of their life, in their 20s. So in the prime of their lives, we're losing a great proportion of individuals with sickle cell disease. So we do need to tread with cautious optimism. There has been a lot of advances made, but there is room for a lot of growth with sickle cell disease. Next slide. So how do you transition into adulthood? There's patients that have various ways of transitioning into adulthood. Fortunately, if you're linked with a comprehensive sickle cell center, which takes care of both pediatric and adult patients, you have a smooth transition, a relatively smooth transition, where you're transitioning from pediatric care to adult care, and you get good continuity of care. This is something that we do over at UI Health through the STAR clinic, the Sickle Cell Transition Adolescent and Adult Readiness Clinic. It prepares the youth and their caregivers for managing sickle cell disease as an adult. And I do see a few people who have been leading that clinic in the last couple years successfully, and transitioned a lot of their patients over to the adult side is when I get to see them. However, not every patient gets the opportunity to transition from an ideal pediatric to adult center or through the STAR clinic. There are patients that get pregnant and often have to go through an abrupt transition for into an adult health setting. And these patients are the ones that are at the highest risk for complications as they transition into adulthood. And then for some patients, they don't have access to sickle cell experts or hematologists. Therefore, they really don't have a point in transition, and their primary medical care for sickle cell disease is coming from ED facilities or inpatient facilities. Next slide. So there's multiple different factors that's affecting transition in individuals with sickle cell disease. One of the biggest factors is the health system factors. We have a lack of adult providers. My pediatric colleagues are very passionate about sickle cell disease. There's on the adult hematology, and though there is still a lack of trained adult providers. And that is the fact of the matter. And when we don't have enough sickle cell disease expert, that's where the loss is in terms of the transition. Also important to keep in mind, a lot of our patients, as they transition into adulthood, they lose their insurance from being under their parents' insurance to either, if they don't have insurance through work, they usually end up losing insurance coverage. And this is one of the factors contributing to poor transition. And then also, as far as sickle cell disease goes, there is overall lower reimbursement from payers, therefore less incentive for facilities and healthcare facilities to invest into sickle cell disease. Unfortunately, sometimes bottom line is the thing that drives a lot of our decisions at the top level. In addition, when patients are transitioning from pediatric into adulthood, there is faster degree disease progression. There's emergent and organ damage. Various studies have shown, especially with nephropathy, you're starting to see more renal issues in adolescents and young adults. You're starting to see more issues with cardiac issues as well as lung issues. And this is what leads to faster disease progression. There's also social behavioral factors where you're going from a very nurturing pediatric environment to an adult world where, sometimes it can be a cold world and you're really having issues transitioning because you don't know how to navigate the system. Next slide. So this is a busy slide, but I wanted to get the point across, as Dr. Saving had mentioned earlier. Individuals with sickle cell disease have multiple organ damage, and some of it is silent, some of it is very apparent, and often in the adults we're seeing patients who are getting into trouble with their heart, their lungs. Usually it's the pulmonary hypertension that's causing significant morbidity and mortality in my patients, as well as some of the things that have not been studied as much in our patient population. These patients are at risk for weak bones, osteoporosis. They're at significant risk for mental health disorders because of having a chronic disease that requires a lot of players. And then a lot of our patients are facing accelerated aging. They're undergoing organ damage in their 20s and 30s, whereas typically the general population is dealing with some of these issues such as hypertension, renal dysfunction a lot later. And then we have to think about the consequences of the treatments themselves. Sometimes the transfusions leads to antibodies. Treating the pain leads to opiate dependence or opiate refractory pain. And all of these issues combined make for a very, very complex adult sickle cell patients, especially if the patient was not transitioned well from their pediatric side. Next slide. So a little bit on transfusion. I just wanted to let you guys know that, blood is actually one of the most scarce natural resources out there. It's especially for sickle cell patients who've had multiple transfusions throughout their life. It's really hard to find matched units. Patients who've had multiple transfusions do develop antibodies, and they're at a high risk for transfusion reactions, both acute as well as delayed hemolytic transfusion reactions. And this is often under-realized by providers. When we're giving these patients transfusions, they may not run into acute complications right away, but they're having issues a week or two down the road. So this is something that we have to be really mindful. Typically, we don't recommend transfusions unless there is end organ damage or high risk for mortality. For a typical vaso-occlusive pain episode, there is no indication for transfusion. Also, when patients are having an active vaso-occlusive pain episode as well as hemolysis, unless there is hypoxemia, there's hypotension, there's some end organ damage, we typically do not recommend transfusions. And that's part of it is because, you know, you can put them at risk for transfusion reactions down the road. And then part of it is also because it's can cause, transfusion itself can cause end organ damage. Next slide. So leading from how does transfusion cause end organ damage? So iron really is the blood products that we're giving in the red blood cells. There's quite a lot of iron, and over their lifetime, if they've had more than 10 units of packed red blood cells, these patients can be predisposed to getting iron overload. And this is what causes a lot of organ damage. Iron really has no place for the body, really has no way of getting rid of iron. The body likes to hold the iron. So once you have enough iron, the body starts depositing the iron in your liver. So you can get hepatic iron overload, which is often seen in our patients with sickle cell disease. And then you can start storing it in the heart. It's not researched as well, but there are newer studies that are coming out that are showing there is some issues with cardiac iron overload. And then the iron can get stored in various organs such as the brain. It can cause issues with your bone mineral density. So it's very important that we're keeping the iron overload component in mind when we're having patients on chronic transfusions. Next slide. And then, you know, we talk about the medical issues that our patients are dealing with, but often forget, you know, the main thing that all individuals with sickle cell care about is having a normal life. You know, a lot of them have significant disability and work limitations because of the multi-system organ dysfunction that they have. And sometimes laws don't automatically categorize patients with sickle cell disease as a disability. Therefore, they do have to jump through multiple loopholes to get on disability, get the appropriate work limitations. So it's important to keep this in mind as we're caring for these individuals. Next slide. So a couple decades ago, we did not expect individuals with sickle cell disease to live into adulthood. Now that they are, what do we do with them? You know, it's very important to continue on with health maintenance, just like you would with any other health individual. This means routine mammograms, routine colonoscopies, checking for diabetes, checking for hypertension. A lot of the issues that can happen in the general population do happen in individuals with sickle cell disease. And in fact, some of the cardiovascular issues are probably even more significant. Next slide. So there was a study done at Duke that interviewed about 19 adult sickle cell survivors, and these are all adults over the age of 40. And the main themes that they got from the survivors was there was significant challenges with sickle cell disease across the lifespan. So not just in pediatrics, these individuals had issues throughout pediatrics, adolescence, as well as adulthood. And then the knowledge and self-management of disease does improve with age. So when you're, you know, seeing your 20-year-olds, your 30-year-olds in the hospital frequently, realize that this is a transition time for them. Things do get better as they know how to, as they get the tools to manage their disease better. and they get hooked up with appropriate providers. And then the third theme that they started seeing is these individuals are surpassing life expectancy, and we really don't know what to do with these quote unquote older sickle cell individuals. Next slide. So this calls for a need for a geriatric assessment in our patients, especially given that they have accelerated aging. That is important. It's important to, keep sickle cell specific geriatric assessment in our older patients with sickle cell disease. Next slide. And then the role of palliative care. Oftentimes when we think about palliative care, we're thinking about end of life care or hospice. However, it is important to keep in mind that sickle cell disease is a very complex disease. There may be individuals who have severe multi-system organ dysfunction, who are transfusion dependent, essentially requiring blood transfusions on a weekly basis. Severely oxygen dependent because of severe pulmonary hypertension. For these individuals and families, it would be very appropriate to get palliative care involved early on, because in our oncology counterparts, studies have shown that there has been an improvement in quality of life in patients who are hooked up with palliative care. So this is something that's really important for the adult providers to start thinking about in individuals who have, severe end organ disease, especially severe cardiopulmonary disease. Next slide. This goes through overall management of acute pain episodes and hospitalizations and other issues that we see in individuals with sickle cell disease. A key point is to realize that individuals with sickle cell disease often are on pain medications for long periods of time. And as they are advancing in age, they may become opiate tolerant. They may require higher doses of opiates, which makes providers very uncomfortable. It also may require additional modalities for care of their pain besides opiates. And we will be talking about that in the next session as well. As far as acute hospital admissions go, some of the common things that we're really looking out for in our patients is acute chest. In addition to that, a lot of our patients are predisposed to getting venous thromboembolic episodes because they're in a state of chronic inflammation. And then you add significant immobility to that when they're hospitalized. So they're at a high risk for getting blood clots. This is why we routinely prescribe prophylactic thromboprophylaxis when they're in the hospital. And then lastly, management of acute ischemic stroke. Typically, when patients are presenting with acute ischemic stroke, we're doing an exchange transfusion. However, keep in mind, these strokes don't just require transfusion, an exchange transfusion. We should coordinate with our neurology colleagues and treat for the stroke appropriately if needed with TPA, et cetera, et cetera. Next slide. So I'm not going to relist the comorbidities. Dr. Saving had mentioned a lot of the comorbidities that our patients can face. On the adult side, like I mentioned, we are starting to see more hypertension in our pregnant women, where we do see quite a lot of preeclampsia, a lot of complications with our pregnancies. In our older individuals, we're starting to see more strokes. So that's something important to keep in mind when we're taking care of these individuals, both in the hospital and the non-hospital setting. Next slide. So we do have a lot of guidelines from multiple societies. The NIH has guidelines. ASH, the American Society of Hematology, has released a few guidelines. How do we implement these guidelines? It's great that we're all talking about sickle cell, raising awareness. Where do we go from here? Next slide. So Dr. Cantor's group over in Alabama came up with a really good model of care for sickle cell. Ideally, you would want an individual with sickle cell disease to be taken care of at a comprehensive sickle cell center. And this includes multiple individuals. It's essentially a multidisciplinary care, and we have to realize not every facility is going to be equipped to have all of these available. Next slide. Therefore, they're proposing various different models of sickle cell care. In the Chicagoland area, we're actually going to be starting a hub and spoke model, where we're starting monthly educational telehealth series for providers next month. And I want you guys to realize that we do have sickle cell experts on call 24/7 through the transfer center line. And if you ever need to connect with anyone regarding management of your complex sickle cell patient, you can call the transfer line and talk to one of the sickle cell disease adult specialists as well. Next slide. So, the road ahead is challenging, but there is a lot of hope. There's a lot of interest that's been generated. So there's a lot of work to do. However, there is light at the end of the tunnel. I want to leave you guys with a positive message. And, there's a lot of work that needs to be done, but there has been a lot of momentum from various organizations at all different levels. So that's about it.
Thank you very much. Thank you, Dr. Saving and Dr. Farooqui. Now we're going to move on to our invited panel. Sorry. It's Jocelyn Mallard. Oh, you're on mute. You're on mute.
Thank you, Dr. Sue, for that as well. My name is Jocelyn Mallard. I'm a research nurse working at UI Health in sickle cell disease. And this panel is comprised of our guests. We have adult sickle cell patients. We have a parent of a sickle cell, a young lady with sickle cell disease, and our providers who just previously spoke. And we can take questions from our viewers here, or we can continue to ask questions. There's a question here that says, at what age do you usually consider geriatric specific care in this population, or is it more of a spectrum? So Dr. Say, Dr. Farooqui?
So from my end, geriatrics is a very heavy word. A lot of people don't like to be classified as geriatrics. But, the fact is individuals with sickle cell disease do have accelerated aging. So, I don't think there is any shame in reaching out to our geriatric colleagues and trying to get help in improving the lives of individuals with sickle cell disease, perhaps even early on when we start noticing end organ damage. And it can vary from patient to patient. I have 40, 50-year-olds that are doing wonderful without end organ damage. And then I have some 25-year-olds that, have significant kidney dysfunction, significant lung dysfunction. So I think that should be provider dependent. And I think that is also something in the future that needs to be looked at and studied further.
A follow-up to that question. So how often do you consult specialties, and do you recommend that your patients have an internist to monitor some of their disease states with sickle cell?
So, I'm a hematologist oncologist by training. I don't remember a lot of internal medicine to be honest with, and I'm honest with my patients. You know, my expertise is specifically now it's more sickle cell disease. So I do redirect my patients for primary care to go see a primary care physician. You know, that being said, as you guys have noticed, a lot of our patients have end organ damage that requires more than a sickle cell expert. It requires someone who's an eye specialist, because you can get into retinal issues. It requires someone who's a lung specialist, pulmonary hypertension. That's not something that I can manage. So it is multidisciplinary care, and we do often, you know, have other specialists involved in our patients' care when needed.
Thank you. Dr. Sabin, do you find it easier to recommend pediatric patients to specialists and have your patients be successful going to see them, or do you too find it a little bit more challenging?
Well, I think a lot of that depends on the specialists, the availability of specialists. So in pediatrics, we use pulmonology a lot, and we use the renal physicians a lot for patients. Those are the difficulties that may come up more often. Occasionally cardiology. We have those specialists here, and it's relatively easy to refer. For preventive care for us, you know, eye exams and dental are very important. And those are the harder things to access in our part of the state because there are fewer pediatric dentists. And we're fortunate here, we have several pediatric ophthalmologists, but you have to wait a while to get an appointment unless it's an acute emergency. But I think one of the things that so it varies with the patient, and we do a lot of assistance with patients for transportation and getting those appointments because they're not, most of them are on our campus, but for a patient, they may not be the same place where their primary care doctor is or their hematologist. And so just getting them to the appointment, it's in a different building, a different system, is often difficult for patients. One of the things we did here too, and I just refer back to Dr. Cantor's paper that Dr. Farooqui was calling out there. We kind of have a new model for our adult clinic here that we just started. It's sort of a specialized primary care model. So we have our hematologist, adult hematologist, and our primary care doctor in the same place, the same clinic, seeing the patients at the same visits. And so in that way, they can talk while they're actually in clinic seeing the patients. And that kind of helps facilitate those referrals and get those done a little more quickly when they're both asking for that same kind of referral. But I think I agree with Dr. Farooqui. For the adult patient, there's usually a lot more specialists that you need to utilize for referrals. And sometimes based on the availability, it can be difficult to get patients to those referrals.
Thank you so much.
I
Welcome.
just wanted to add one more thing. From an adult standpoint, a lot of our patients are sick of seeing doctors. You know, in an ideal world, I wish we had something that Peoria has, where, you know, you have your primary care doctor there, where you have all of the specialists at one clinic, where the patient is going through multiple doctors in that one visit instead of having to run to 10 different appointments. You know, that's something I do hope to see in the future.
Mm-hmm. I think that's what makes pediatrics at UI Health a little different as well. The specialists and sickle cell and the pediatricians are all in the same clinic, and that does help promote better care and ease of care. I'd like to thank and welcome Ronisha Edwards-Elliott and Thelma Lawson. Thelma is the parent of a young lady who has sickle cell disease, and Ronisha is a patient herself. Ms. Lawson, I'm going to start with you. How old was Iris when you started talking about sickle cell?
Hi, Jocelyn, and hi, everyone. So when we started talking, educating her about sickle cell, or
yes,
when? Okay, so we've always kind of just said, just told her like she has sickle cell, because when Iris was, I think 1, that's when she had her first crisis, and it was after her shots. So after 2, I mean, we just kept talking about it. And so I think when she was between 4 and 5, that's when she actually understood, okay, I always have to make sure I stay hydrated, understanding what sickle cell is and how to manage it. because our biggest thing was teaching her. So when we are not with her, she knows what to do and she knows the signs. So my hands are getting warm, so she knows what to look out for.
And how old is she now?
Iris is 10 years old.
Wonderful, wonderful. So you basically started teaching her very early.
Yeah, we tried. Yes.
We can only try, right?
But, yeah.
Does she ask you questions about her disease?
Yes, and I think, you know what, she's also blessed. Like, you guys are all wonderful at UIC, because I really I remember one time we came and saw you and you were asking her, oh, do you know what sickle cell is? Do you know what it means to have SS? And so I feel like also that helped her own it. She realized it wasn't just like mom and dad telling her to understand what sickle cell was, but her providers were also putting it on her to know this is what it is to have sickle cell, and these are some of the things I need to do about it. So I think that helped her quite a bit. Overall, though, I feel like now she has a better understanding. So she would like occasionally will say, do you know what it means to have SS? And do you know what are some of the signs to look out for? And now I feel like now she's really comfortable. She has been for, I think, a few years now, where she knows, you know, she'll be like, oh, you know what, I feel a little warm. And I'll be like, how are you drinking your water? And she said, oh, maybe I just drank one bottle. So I need to, and then she would go get her water bottle and start hydrating because she knows I need to keep drinking water. And it's the same with like the cold, me being able to like regulate temperatures, knowing that, oh, when it's so cold outside, I have to make sure that, you know, I bundle up, I'm wearing my layers. And if it's over 7 degrees outside, ask the teachers to stay inside so she's not outside.
Oh, wonderful.
So,
wonderful.
Yeah.
So she's basically owned her disease to a point where she's able to advocate for herself even at school.
Yes.
Oh, that's
She was telling me, last school year, she was telling me, she said, oh, it's now they're making us go outside when it's like 25 degrees. Mommy, you need to tell them that it's too cold for me and I can't be outside.
Oh, wonderful, wonderful.
Because I've been teaching her how, you know, we want her to be active. You still want to be active, but at the same time, you have to balance between being active and also paying attention to your body when your endurance is low and you know, oh, I need to take a break. So pacing yourself.
Awesome. How active is Iris in speaking to her providers when she goes to her appointments? How engaged is she?
So Iris has been a journey. So Iris initially was very shy and reserved and wouldn't want to talk. And now she's at a place where she's opening up and she'll talk to a provider. She'll answer the questions about school and how she's doing. And she'll tell them when she takes her medication. So now she's pretty involved in her care.
So you allow her to speak for herself. You're there, but she does most of the talking. See, that's
wonderful. I encourage her to do that. Yeah, I encourage her to do all the talking.
Good, good. Ronisha, welcome.
Hello.
Could you describe your pediatric to adult transition for us?
Yes, so I know we heard wonderful things today about what happens in transition and the hope of patients having transition programs, but I myself was not a part of a transition program. It was a thing when I transitioned, but unfortunately, as we heard earlier, I was someone before the Affordable Care Act that lost their insurance at the time of my transition. And so it was about 2 to 3 years before I was able to get insurance again. And at the time of finally regaining my insurance, I was very critically ill. At the same time, I was a young adult that thought I had it all figured out. And I had decided that since I lost my insurance and I was tired of sickle cell disease ruining my life, that I no longer had this disease, and decided to just keep it a secret. And so dealing with the stress of being a new student in college, navigating adult relationships, and then not having my regular care as I once had in pediatrics, I found myself really having to start over from square one once I did finally get care again in my early adulthood.
Awesome. So I take it that you did not have an opportunity to participate in a transition program.
No, although I was equipped, I understood my disease, I understood, you know, everything that was going on in my body. My mother was very much like Miss Thelma. She instilled in me to advocate for myself, to be aware of what my body was saying and how I needed to share my disease, not participating in a transition program. I lacked the core element of really not having shame or guilt about having sickle cell disease. I was tired of just having to sit on the sidelines while I felt people were living a normal life. And so because of that lack, I really suffered without a program such as that.
So I have to give credit here. Ronisha is one of the reasons there is a transition program at UI Health. She took her experience and she worked with Dr. Rivers, and they developed the transition program that we're instituting at the center right now. So I thank you for that. I have a question to ask you all. What age do you think is appropriate for transition, and what skills do you think the patient should have that will allow them to have a successful transition? So I want to start with Ms. Lawson. What age, right now, if you were looking at Iris today and you said, okay, in 10 years, she'll be ready for transition, or 6 years, she'll be ready for transition, what age do you think would be appropriate for her? We'll speak for her specifically. And what skills do you think she needs to master to successfully transition?
So I would say, so Iris is 10 years now. So I would say by 16, I would believe. I would say maybe age 16. Can you hear me?
I can.
Yeah. So the skill, in terms of skills, I feel like you should be able to advocate for yourself, understand, you know, the scope of your illness, understand what your strengths and limitations are, and be able to explicitly like advocate for yourself. And I feel like the advocacy piece is like huge, because there's a lot of people who really do understand like what sickle cell is, what the limitations are, how it expresses itself. So I feel like that's like one big piece. If you like understand how that impacts you, and being able to like advocate or educate people around you, that's like half the battle for you as like a patient, so people can kind of support you. And yeah, I feel like 16, so I feel like being able to advocate for yourself, meet your self-care needs, will be good skills to have.
Dr. Sabin?
Yeah.
Well, I think we have a transition program here and are really working hard to improve that. I think what we do here is we start at about age 12 to 14 doing the teaching and training and assessing sort of where each individual patient is, and continue that until they transition. So we're trying to equip them best for that. And in our place, in our center, it's pretty individualized. We have some patients that would be ready sooner than others. Some it takes a bit longer to get there. I would say for the most part, historically, we've transitioned patients to adult care when they're complete. Usually we keep them in our clinic until they're complete of high school. And then we would transition them to an adult provider if they were ready. We've kept some for years after that. I think it is, for us, it's been really individualized. We've not had adult providers, adult hematology providers. We now have one. That's been one of our biggest problems in transitioning. If you don't have a provider that the patient knows and trusts and that you feel comfortable transitioning to, that's a real problem. And that's a problem across the United States. As Dr. Farooqui mentioned earlier, it's a big problem. But we have a number of things we want to make sure that they understand the disease. As Thelma said, we want to make sure that they know how to make appointments, that they can advocate for themselves. We also I try to make sure that their disease is in as good control and as stable as possible, and get screenings and other things completed and out of the way so that there's not something that needs to be done in that transition period. We're trying to take care of as much of that as we can medically, so that we're not sending them off with other things that need to be done immediately.
Mm-hmm. Dr. Farooqui, you're receiving these young people. What are your expectations? when they come to you?
So navigating the health system is really hard. You know, me being a physician, for me, sometimes it's a challenge. So I think it's important that, you know, these patients are prepared on how to navigate the system and educated on how to navigate the system. You know, each facility is different, and understanding how the facility works, just something as simple as how do you refill your pain medications, you know, where do you go if you're having pain? Is there an infusion center that you can go for an acute pain crisis? You know, we at UIC, we do have the acute care clinic where they can come and get evaluated for a pain crisis versus do you just go to the ER? Things like that, I think, are important for the patients that are transitioning. And I agree with Dr. Saving, you know, it's very individualized, it's patient dependent. One thing that Jocelyn, you and I started when I first started, and I think that has really helped some of my patients, has been, you know, having the adult hematology provider see the patient as they're transitioning, so they can build a relationship not just with the patient but also the patient's family. You know, and having some input from the adult provider and having the adult provider get familiar with the patient even before they come in, I think that's worked out really successfully, at least for the patients in my clinic that I've inherited from the STAR clinic.
That's good to hear. Thank you for that.
Yeah.
Ronisha, how important do you think parents are in the transition process? And do you think there's education that the parents need to receive as well as the patient themselves?
Absolutely. So my answer is probably a twofer with your other question coupled with this one. So I first want to say that transition is definitely individualized, but preparation definitely needs to begin at 12 to 14. As a patient is transitioning into high school, we need to understand that sickle cell disease is a life factor, and we do them a disservice not helping them to transition every element of their life while living with this disease. So as the school is preparing them for college or whatever that next stage of life is, we also need to be looking at how sickle cell disease will play a factor in that, and not when a patient has made the decision already, but helping them to understand that maybe they should make their life decisions framed around their sickle cell disease or take it into consideration. I think caregivers coupled with that play an important part. They need to understand that their caregiver is a team player on their team, and once they will relinquish their control and not make a decision, and they will be able to have autonomy and that self-determination to make their own decision. But as kids, as young adults, we don't always feel, you know, capable of just making those health decisions, but we need that motivation and support from our support system. Even now, as an adult with sickle cell disease, I don't know some days when I'm sick what I would do without my mother. I'm a very capable advocate for myself. I understand my disease, very capable of speaking, but still, she is still one of the warriors in my life that battle for me when I'm not able to. Pain is we should not expect people to talk in pain. And so caregivers go along with the process and they transition too. So they require that same education. They require that same support. They require that same motivation to maybe stop hand holding and maybe stop coddling, but understand that as the adolescent is going through that process, that it's okay that you are going through it too.
Thank you for that. Thank you very much. Are there any questions from the participants? I hope one of the participants had a question that says, at UIC, we have a special clinic to help transition patients from pediatrics to adolescents. We just talk about the STAR clinic. I know that's not the case everywhere, and this can be challenging. Wonder if panelists can share their experience with this transition. I'm wondering if you specifically mean transitioning from the STAR clinic to adult care. At this point, I don't believe Ronisha did not participate in that program. but hopefully Dr. Farooqui did address your question. She does receive our patients from the STAR clinic, and those that have transitioned within the new model that we have, it has been successful. So I do appreciate her giving that information. Having a day center, having a day clinic, Ronisha, do you think that has been in addition to helping our patients stay out of the hospital and potentially be exposed to the adult providers a little bit more and help in the transition where they don't have to go to the ER? Their experience is in the adult center and participating in acute care. Do you think that aspect is one additional piece that does help in the transition?
Yes, I do believe so. I believe that one of the biggest things that patients in transition really need to understand is the difference between pediatrics and adult clinic. And I think all here we're very aware of what sickle cell disease treatment looks like, and it is very different from pediatrics. It's no one calling and saying you haven't been to your appointment, what's going on. It's more up to you to be accountable for your health and your wellness. And so when patients are able to see that in adult settings like day clinics, they are able to become accountable, become more responsible, but also understand what adulthood is like with sickle cell disease. Also, the emergency room takes a lot of time. The day clinic is very beneficial for us to get back to our lives. And so I believe that we will have more medically adherent young people when we help them to understand that you can still take care of your body. Sometimes sickle cell disease may sit you down or feel like it limits you, but there are modalities for getting treatment where once you are well, you can get back into your everyday normal. You're muted, Jocelyn.
We have a question from Talana Hughes. She is the Executive Director of the Sickle Cell Disease Association of Illinois. Welcome, Talana. It says, from your experience and perspective, how can the sickle cell community-based organizations assist in the transition process for the parent, the individuals with sickle cell disease, and the healthcare team? Excellent question. Anyone want to tackle that one? So what part do CBOs play, or what part can they play in the transition process with parents, individuals, and the healthcare team?
Well, this is case saving, and I'll make the comment that I think two things that come to mind. One is just in general education. So they certainly are very good at educating patients and families. And so if as we're transitioning a patient, we need some assistance with specific educational components, I think they can be very helpful there. I think they also could be very helpful in educating and helping families make the other connections that you need to make as you're doing transition. So with other medical care providers, with other social service agency providers, even I think assistance with some of the, as Dr. Farooqui was saying, learning how to navigate that medical care system, because they look at it at a bit of a different perspective and would have a different kind of experience with some of those agencies and those issues than perhaps the medical providers would have. And so I think they can be very helpful in those two particular aspects. Certainly, they also would know about support groups and those kinds of other things that would be available to patients that medical providers might not be aware of, those extra kind of services that could just be supportive for the patients and families.
Excellent, excellent. Anyone else?
Finances are a huge deal, especially in patients who are transitioning from, being primarily supported by their parents to having to live independently, figure out your own finances, figure out your own food and shelter situation. There are some of our patients that are food and housing insecure. So trying to link our individuals with sickle cell disease to, job opportunities, that would be very helpful. Trying to get workplace administration, learn more about sickle cell disease, just advocacy on that end. Colleges to make accommodations for individuals with sickle cell disease who are in undergraduate or graduate school. I think some of those things the community-based organizations can really help our patients with.
I
Well,
just
thank
want
you.
to add,
Yes.
Jocelyn, that one of the worst parts of transition is isolation for the patient, of just feeling alone in this process. Sickle cell disease is a very isolating disease where you feel alone, even if you do know others with the disease. And so I think that CBOs are very important for building community. But what is important is that as a medical community, we sometimes when you're isolated as a patient, you don't know how to ask for help, or you may not show that you need help in that element. So when we normalize embedding CBOs as a part of medical treatment, it just makes community more of a norm for patients. So we just need to do more of working together and just embedding CBOs as a normal part of our work in transition.
Thank you so much. Our time is up. So I just wanted to thank Dr. Saving, Dr. Farooqui, Ronisha, Edwards-Elliott, Thelma, Lawson for your insights about transition and the whole of transition from families, caregivers, and patients. So I appreciate your time. And now I will turn it over to Dr. Sue.
Thank you very much, Ms. Jocelyn Mallard. And I think it's time for a break. So we will reconvene at 11:30. So you have 4 minutes. Don't be late. Stretch your legs, drink some water. We don't want anybody to get dehydrated or get a blood clot on our watch. All right, hopefully everybody has stretched and hydrated. Welcome back to the Chicago Sickle Cell Summit. I'm Louis Su. My pleasure to introduce my close friend and colleague, Dr. Wanda Whitten-Shurney, who is coming to us with at least two hats. One is that she's the lead for the Sickle Cell Disease Association American Michigan chapter, but she's also a physician who takes care of children with sickle cell disease in the Detroit area. Dr. Wanda Whitten-Shurney. Oh, you're on mute, please.
Okay,
And we got your
can
slides.
you hear me?
Great.
Okay, got my slides. Now let me get it to the point where it's a slideshow.
You're still on mute.
Okay, well, let's see.
I can hear him.
You can hear me?
We can hear you.
Yes.
Okay, I wonder why
we got
Dr.
you.
Sue can't
Okay.
hear me. Can you hear me now, Dr. Sue?
Yes, thank you.
All right, so
Sorry
Um,
about that.
it's okay. Had me in a panic there for a minute.
No, please go ahead.
Okay, so first I want to really thank the organizers for inviting me to this meeting. And I want to thank the presenters and the panelists for kind of really giving me a nice segue into my talk. And once I find out who it is, I'd like to know who came up with the title of this talk, because I think it's a fascinating title and it really got my wheels churning. And I am excited to talk about why does a sickle cell disease genotype matter? So let's talk a little bit about that. So I have a disclosure slide. I am a consultant for Pfizer and Vertex. And also I have the disclosure that I am not a hematologist. I'm a general pediatrician. I spent 30 years in the Comprehensive Sickle Cell Clinic at Children's Hospital of Michigan. And, I started thinking about this genotype and this phenotype business. And it was a William Johansen, who was actually a plant biologist, who coined the phrases genotype and phenotype. And so the genotype is the set of genes that you carry, but the phenotype is all of its observable characteristics, which of course are influenced by the genotype and by the environment. And so it's like for sickle cell disease, your genotype is SS or SC, your phenotype is how it's your personal struggle, your personal story. And of course, it's impacted by what your genotype is, but it also is impacted by your stress level, the quality of care that you get, and a tremendous number of other things, what the weather is like where you happen to live and that kind of thing. So before I really dive into the, let me get this out of the way. Okay, I dive into the whole genotype thing. I wanted to say something about the phenotype, okay? Because there is something called phenotypic heterogeneity. And that is something very characteristic of sickle cell disease. And so, it's like every snowflake is different. Every individual living with sickle cell disease, who frequently refer to themselves as warriors, which I think is really appropriate since there's this ongoing battle. But, I've had people always ask me, well, what's the worst type of sickle cell disease? And my constant answer to that question is the worst type of sickle cell disease is when you're sick, because there are people with the SS type who do well. There are people with SC and even sickle beta thal plus that have a lot of complications. So I don't want people to get tied up with, oh God, I have the worst type of sickle cell disease, if they are actually what Andrea Matthews says, living well with sickle cell. So I think that's an important issue. Now, let's get to the genotype. And so I'm sure everybody knows about SS and SC. And most of you probably know about sickle beta thal 0 and sickle beta thal plus. But I don't know how many of you know about SD and SE or SO Arab. And then, I at the Sickle Cell Disease Association of American Michigan chapter, we serve as the coordinating center for newborn screening for blood diseases. And just last week, I had a case that came back SV, which is an unusual variant that we then send to my friend, Dr. Elliott Vachinsky, to tell us what the variant is. And it was SL Desirade, okay? And see, I'm even having trouble pronouncing it, never heard of it, but they told me in the comments that it was a mild form of sickle cell disease, and of course, a very rare form of sickle cell disease. So let's talk about these genes a little bit more. Of course, these genes came about, this genotype came about because of a mutation. And then having sickle cell trait or only getting one sickle gene actually protects you from malaria. Now, if you get two sickle cell genes and you have sickle cell anemia, then you are less likely to get malaria. But if you get malaria, you're more likely to die from it. So of course, having sickle cell trait, living in places where malaria is endemic, puts you at a definitive advantage because you're more likely to live, and then living, you're going to have more children. And actually the incidence of sickle cell trait in Nigeria is 25% because malaria is such a driving force in Nigeria. So, you know, you might think that if you were to superimpose a map of sickle cell disease over a map of malaria, you would see that they should fit right on top of each other. But as you know, we don't have malaria in the United States or anymore. Well, there seems like there are a few cases down there in Florida, but it's not prevalent in the United States. So you might wonder, why is it that we have sickle cell disease in the United States if we don't have malaria as a driving force? And whenever you see sickle cell disease where you don't see malaria, it's always from migration. And in this case, it was the transatlantic slave trade was the migration that brought sickle cell disease to the United States. And, you know, when I look at these people, these human beings that are being treated like cattle, you know, I can't even imagine how horrendous that must be. But how horrendous would it be if you were someone living with sickle cell disease and in pain, in addition to just the pain from to going someplace you never heard of and being taken by people, and you know how afraid you must be, and then you're having a sickle cell pain crisis. It's almost unimaginable. And you know, I think about our ancestors, you know, and how they were able to survive so that we might live. And I'm always thankful to my ancestors. And, you know, I have had a number of life-changing experiences. I'm sure everybody has. Of course, the birth of both of my children. And now I have a grandbaby that is just, she's a month old, and it's just like unbelievable how much joy that brings to my heart. But I'd like to share two other life-changing experiences with you. And one was a visit to Senegal, where I went to the island of Gorée. I was with my dad, and he was giving talks about sickle cell disease in West Africa. And I visited the slave castles there. And I was about 16 years old. And here's my picture. And I think you can kind of see the look on my face, and I can kind of remember what it was like, you know, being in that space and thinking about, you know, how, you know, the history of sickle cell disease and how the genes got transported to the United States. And then in the year 2000, I made it to Ghana. And I went to the Cape Coast slave castles, and we were actually able to go through a ritual where you washed your hands and your feet, and you wore white, and you know, actually, they talk about the fact that you could kind of feel the presence of the ancestors and almost smell, you know, what it must have been like. And, you know, I feel like I'm pretty well educated about Black history or African-American history. But I didn't know about the folks that were just thrown into rooms with no clothes and there for months waiting to go God knows where. And, you know, somebody might die next to you, or somebody, you know, no bathrooms, or it's really unimaginable. And those were really two life-changing experiences for me. But, you know, if we get back to this whole genotype thing, right? It was Vernon Ingram that first described that this was a single point mutation. It was glutamic acid to valine. And that caused the hemoglobin to, instead of being in solution when the red blood cell gives off oxygen, to line up or polymerize. And that's what causes the whole issue with this unusual shaped cell. Now, in hemoglobin C, it's glutamic acid to valine, another point mutation. And the fact that this was a point mutation, when I was in medical school at Howard University, they were saying, oh, we're going to fix this. This is easy. We're going to have a genetic cure for sickle cell disease in the next 5 years. Well, I graduated from medical school in 1983. And we still don't quite have a perfected genetic cure for sickle cell disease, although it's on the horizon. And one of my favorite slides was Dr. Farooqi's slide that showed that there's light at the end of the tunnel. So, and then Dr. Savings showed this slide. And if you go to any sickle cell conference, you're probably going to see this picture. It's a photograph. It's an electron micrograph of a sickle cell. And the genotype or this mutation causes the red blood cells to take on this shape, and I think the reason that you see this slide is because a picture is worth 1,000 words. And I think it's very clear that this is not a good cell to be coursing through your body. I mean, a 6-year-old would say, hey, well, this looks bad, but this looks good. This might be a pillow I could lay my head on, but this is not a good thing. So it really helps us to understand what's going on with sickle cell disease. And Dr. Savings already did a really good job of this for me, but one of the things is the blockage in the blood vessels. And when you have that blockage in the blood vessel, then that stops the flow of oxygen and that causes pain. And equally as important, it causes organ damage. So of course, pain is the hallmark of sickle cell disease. And it's kind of like, as a pediatrician, I was really always focused on pain. It's like seeing these kids in pain and watching their parents watch them in pain and having the parents feel like, man, I wish I could take this pain on for my child and not being able to do that. And the thing is, pain is loud, okay? So that's something that everybody is pretty much aware of. And, the pain is real. And the pain needs to be managed. And this whole idea that individuals with sickle cell disease go to the emergency room with the hallmark of sickle cell disease being pain and get accused of being drug seeking. And one of my mentors, Dr. Donald Rucknagel, taught me that the #1 cause of drug seeking behavior is pain. And the #2 cause is fear of pain. You get in the hospital, you wait for hours in the emergency room, you finally get admitted to the floor, you get the PCA pump, and the next day they're walking into the room saying, okay, you look fine, we're gonna wean your pain medications. It's like, oh my God, no, I haven't even had a chance to catch my breath. So it's really important, and in a number of our walks, we always try to emphasize that sickle cell matters. In one year, it was because the pain is real. And we had another walk where it was a myth dispelling walk. And the warriors wore t-shirts that, talked about all the myths in sickle cell disease. And so one of the shirts was "My pain is real." And another shirt was "Living well with sickle cell," because it's a misunderstanding that everybody with sickle cell disease is deathly ill all of the time. And another thing is "I'm still here. Living with sickle cell disease" was another shirt. And once again, one of the most exciting things that I've heard thus far on this conference is the talk about geriatrics. And imagine that. We need geriatric care for people with sickle cell disease. Now, the second problem with these red blood cells that Dr. Savings already helped me with is that they are fragile and they break down early. So they leave the bone marrow, they enter the circulation, eventually they wear out. If you don't have sickle cell disease or another hemolytic anemia, your red blood cells stay in the circulation for about 5 months. The problem with red blood cells that contain sickle hemoglobin is they break down rapidly. And that's what causes the anemia. And it's the anemia. Okay, what did you do there, Wanda? Let's go back here. And it is the anemia that causes the fatigue. And another myth that sickle cell warriors are lazy. Well, if you're walking around with a hemoglobin of 6 and your hemoglobin is supposed to be 12 to 14, then you're going to be tired, not lazy. But the other important thing about the breakdown of the red blood cells, or the hemolysis, is that when the red blood cells break down, they release hemoglobin. And the body does not like to see free hemoglobin in the circulation, right? The body wants to see hemoglobin packaged inside the red blood cell. And when the hemoglobin is released into the circulation, it can also add to the organ damage. So of course, sickle cell disease affects every part of your body because every part of your body requires oxygen. But one of the points that I really want to make, I talked about the pain being loud. The organ damage is silent. And it's like I've had so many warriors say to me, I don't want to try disease modifying therapy. I don't have much pain and everything is okay. You know, well, everything is not okay. And I'll ask them, well, what is your hemoglobin? And they'll tell me 7. I'm like, okay, so you're hemolyzing, and that's a problem. And that's something that now we can do something about. And I know you're going to hear more about a medication that does something for hemolysis later on after lunch. Now, we've already covered, Dr. Savings has covered the complications of sickle cell disease, so I'm not going to go into any detail, but, you know, the increased susceptibility to infection, the yellow jaundice that makes you identifiable. You know, if you in the supermarket and you see a baby with Down syndrome, you can look, oh, that baby has Down syndrome, but you can't necessarily look at a person that has sickle cell disease and say, oh, I think you might have sickle cell disease. Now, some warriors can do it to each other, but this yellow jaundice is something that makes you identifiable, something you get asked about, something that warriors get bullied about, yellow-eyed monster, and ask, why are your eyes yellow, and these kinds of things, you know? And then, of course, there are the gallstones from all that breakdown of the red blood cells and release of hemoglobin. And then there's the avascular necrosis and the pulmonary hypertension, and the problems with the eye called retinopathy and trapping blood in the spleen, and stroke, which I think is probably the most feared complication in sickle cell disease when I'm talking to young mothers and fathers and grandparents about this new diagnosis of sickle cell disease, because it's like, oh my goodness, you know, I'm just waiting, you know, for my child to have a stroke, you know, and people just keeping sickle cell disease just in the forefront of their minds all the time. And then, of course, there are these horrible leg ulcers that are so painful and look so bad and are so difficult to treat. So, you know, there's some good news, and people with sickle cell disease are living longer and longer because of the advancements. So these genotypes are doing better, but we still know that the average lifespan for a sickle cell warrior is decreased by about 30 years as compared to someone that doesn't have sickle cell disease. And, you know, although people are living longer and longer, what we really want is to improve the quality of life, because people are not living better and better. So once again, the disease modifying therapies that will be talked about later are really important in terms of improving the quality of life. You know, here's another big problem with this genotype. So, you know, people don't use Webster's dictionary anymore. Everybody Googles everything. And it's my feeling that if you go to Google and type in healthcare disparity, and then you click enter, there should be an individual living with sickle cell disease, who would of course be Black, and a picture of an individual living with cystic fibrosis, who most of the time is going to be white. And, you know, I frequently say that sickle cell warriors are the face of healthcare disparity. So we had COVID-19, right? And that's like, oh, all of a sudden everybody knows that there's healthcare disparity, you know, but, and you might ask, well, what's the real evidence of that? And this is a study that was done in 2006 by Smith. And a lot of you may have seen this slide before, but at that time, there was estimated to be about 80,000 people with sickle cell disease and about 30,000 with cystic fibrosis. And let's look at the individual federal funding per individual for sickle cell disease. Okay, so that, you know, money is a huge issue. Money makes a big difference, right? And you may say, okay, well, Wanda, this study was in 2006. Okay, so let me just show you another study in 2018 by Farooqui and others. And we still are seeing the same discrepancy in funding. And when you have a discrepancy in funding, then you don't have as many clinical trials, and you don't have as many new medications. And in fact, in 2018, there were 4 disease-modifying therapies that were FDA approved for cystic fibrosis, and only 1 for sickle cell disease. Healthcare disparity is a huge problem with this genotype, and that's why this genotype matters. So, you know, this is 2 landmark articles that have to do with the genetic cure for sickle cell disease, right? One by Julie Cantor and the other by Dr. Fangul. And it let us know that, okay, we can fix this. We can fix this disease. We can cure this disease with something other than a bone marrow transplant from your brother or sister. Because if we're trying to do that, then sometimes you have to have a full brother or sister. And we have blended families, so sometimes we don't have a full sibling. And then there's the possibility that the full sibling will also have sickle cell disease. So, you know, there's a big problem in terms of finding donors when you're having a stem cell transplant from someone else. But the genetic cure for sickle cell disease is really a stem cell transplant using the warrior's own bone marrow, which is being genetically modified. Okay, so there are a couple of issues with that. You know, well, the good thing is you have a donor because you have the warrior and they're going to be their own donor. But there's a problem that we still, you know, the bone marrow on sickle cell disease is very full, you know, and so we have to make space in the marrow. And the way we do that is with a conditioning regimen. And right now it is mostly busulfan. And busulfan can cause you to become infertile, and busulfan can cause late effects like leukemia. And we've actually had at least one warrior that I know of die from complications of myelodysplasia and developed leukemia, had a second bone marrow transplant and passed away. So the other thing that I'll say about this genetic cure is that in speaking to warriors, you know, some of them feel as though we really shouldn't use the word cure, you know, because if you're, you know, 30 or 40 years old and you have kidney damage and liver damage and heart damage, and like I say, every organ of your body is affected, and we take away the sickle cell disease, we're not really making the warrior whole, right? And so I don't know, maybe transformative has been something that we've talked about, but maybe cure isn't the best word, at least for sickle cell warriors, to describe this genetic cure. And the other thing is that, you know, there are a lot of characteristics of sickle cell warriors from my experience. And one is that they're brave and that they're resilient and that they're caring and that they're loving, you know, but another is that they're very skeptical. You know, and so, you know, we don't want to eat genetically modified food, but now we're talking about genetically modifying people, and that's kind of scary. And, you know, I was actually on a panel where Dr. Su was in the audience, and he raised the question, or he made the point that if you're talking to warriors about the genetic cure for sickle cell disease, and they ask you about the long-term complications, then a very honest answer to that question needs to be, I don't know what all of the long-term complications might be. And so long-term follow-up is really so important in terms of this genotype and why it matters. So thank goodness there are warriors who have started programs that are nationwide. Some of them, you know, even cover the globe. But Tiana Wolford, she underwent a bone marrow transplant. The doctors told her that if you don't get this transplant, you're going to die. So she said, okay, I better get the transplant. So she got the transplant and it failed, but it did leave her infertile. And so, you know, Tiana was looking into fertility preservation, and she found that there were lots of grants for people with sickle cell disease, but for people with cancer, but not for people with sickle cell disease. So she said, oh, what should I do? Oh, I should start an organization. So she started the Sickle Cell Reproductive Health Education Directive. And she's doing things for other warriors that she can't even do for herself. So, you know, when I talk about describing warriors as brave, this is a huge example of that. And I'm giving you a plug for her conference that is coming up from April 18th to the 21st. I think it's going to be really exciting and everybody should go. So now another warrior, Marcus, and his sister, Ashley Valentine, started Sickle Cells, and they elevate the voices of the sickle cell community and influence decision makers to propel positive change. And any of you who knew Marcus or who know Ashley know that they're a powerhouse and how important advocacy is, because this genotype matters. And then, of course, there's Cassandra Trimnell and Sickle Cell 101. And their mission is to educate, empower, and connect the global sickle cell community through targeted digital engagement and data-driven initiatives. And so, you know, I think as some of the panelists were saying, education is so important, and self-care is really so important. And she has a video on YouTube called Why I Take Hydroxyurea. And, you know, I feel like, you know, for a long time, and even now, I'm a drug pusher, and the drug I push is hydroxyurea. And I frequently say to warriors, you know, maybe you should talk to someone else who's taking hydroxyurea. And she actually has this video that people can access at their own convenience to learn why it is that she decided to take hydroxyurea. It's one thing for a doctor to tell you that you need to take hydroxyurea. It's another thing for another warrior to share her positive experience. And of course, there have been people that have had negative experiences with hydroxyurea too. And so, you know, everybody has to make a decision that they think is in the best interest for themselves. And then, of course, there's Dr. Lakia Bailey, who has a PhD in molecular hematology. So she can tell you something about this genotype. And she started the Sickle Cell Community Consortium, and she says nothing for us without us. And she also says that going to the emergency room is like making a decision between dignity and death. Because if you think you're going to die, then you swallow your pride and you go to the emergency room and you wait for hours, and you get really frequently you get really poor treatment. So, you know, I think that there's another genotype that we should talk about. The talk is the genotype of sickle cell disease, but let's talk about AS, or the genotype for sickle cell trait. You know, and why is that important? It's important because from my personal experience with newborn screening and calling mothers and telling them that they have sickle cell disease, frequently the mother will say, oh, that can't be because I have the trait, but the father doesn't. And I'll say, oh my goodness, how do you know the father doesn't have it? You know, and she'll say, because I asked him, you know, or I asked his mother, you know. It's like, oh my goodness, you know, he probably doesn't even know what it is. He knows he's not sick and he figures whatever. And I don't have this, and maybe this isn't my baby. And oh my goodness, now we're calling into question, you know, the mother's, you know, maybe there's been some infidelity, right? And then, you know, we bring him in and test him, and of course he does have sickle cell trait, or maybe he has the C trait, or maybe he has beta thalassemia trait, you know. And so now we've got to go back and we've got to heal this family. But, you know, I think it's really important for people to know their sickle cell trait genotype, or their sickle cell genotype, because they need to be able to make informed decisions about childbearing. You know, the way we're going to wipe sickle cell disease off the face of the earth is with a cure. You know, we're not going to do it by telling people who both have sickle cell trait, or a sickle cell warrior that has the disease and his partner has sickle cell trait, oh, you can't have a baby. You know, why would you bring somebody into the world that, you know, is going to suffer like that, you know? And there are people that really feel that way, and parents that get accused in the emergency room, well, how could you do that? Didn't you know you had sickle cell trait? How could you bring a child into the world? You know, and I'm like, I don't know any sickle cell warriors. I know they have struggles and have ups and downs, but I don't know of any that, you know, really felt like they never should have been born, you know. And so I think it's important for people to be aware that even you can have a baby with sickle cell disease, even if you don't have sickle cell trait, because you might have the C trait or you might have beta thalassemia trait. So it's really important to educate people about these particular genotypes too, because they matter. I think that, you know, one of the difficult things is that with newborn screening, I think newborn screening is fabulous. I think that we have to diagnose it at birth so that we can get life-saving penicillin, because that penicillin prophylaxis study showed us, I mean, there were 3 babies that died who were on the placebo arm, you know, so these babies gave their lives, as Dr. Frempong would say, so that other babies might live. But, you know, one of the downsides of newborn screening is the fact that this family has this nice new baby, nice and juicy, and has 10 fingers and 10 toes, and they're thinking everything is fine. And then somebody picks up the phone and calls them and says, oh, your baby has sickle cell. And they're like, oh my God, what are you talking about? Who are you, Dr. Whitten? What? How'd you get my phone number? Click. You know, and it's, you know, if you don't know about the possibility of having a child with sickle cell disease, then that information can be, I mean, it's always bad news, but it can be just absolutely devastating. And it can impact the way that you're able to care for your child very early on. A lot of these parents, they just kind of go into denial. It's like, I tell them that they have to have a confirmatory test. And oh, okay, so if you have to have a confirmatory test, and maybe the first test was wrong. It's like, no, the first test isn't wrong, but the state requires us to do a second test. Well, get back to me when we have that second test. And then it's really a thing to get them to get that second test, because they don't want to confirm that their child has sickle cell disease. So, you know, at least if you know ahead of time, and on very few occasions, I have done prenatal education about sickle cell disease, and almost never preconception counseling about sickle cell disease. But actually the chair of my board is the Wayne County prosecutor, Kim Worthy. And she was adopting a young baby, and she found out the baby had sickle cell disease. And she called me and she said, Wanda, tell me about this whole thing. And so I did a complete educational session with her. And she was like, oh, okay, I can handle that. So she adopted this child with sickle cell disease, and now she's in law school. You know, so I always talk about Kim as being someone who literally made an informed decision to have a child with sickle cell disease. So let's talk about the impact of this genotype, because it's the impact of the genotype that is really why it matters, okay? Because what does it do for warriors? It interrupts every aspect of their lives, kind of like, you know, out of nowhere. You know, you just, it's kind of like you feel like you can't plan anything because you don't know when you're going to have this next pain episode. And so that takes us to the mental health issues. I think some warriors actually have PTSD, you know, because of what they've been through, you know, and we know that the incidence of depression is highly underestimated, and that mental health is now, I'm glad, being addressed much more directly for sickle cell warriors, and that's important. They frequently will isolate themselves, you know, and the thing that I learned is that sometimes they don't want anybody to know that they have sickle cell. And I used to think that maybe that had to do with shame, but I've learned that it has to do with not wanting to be treated differently, not wanting people to feel sorry for you, you know. And then, you know, with the parent support group, with the adult support group that we're having now, I'm learning about the guilt and how warriors say that they feel guilty, that they sometimes interfere with what's going on with the family. You know, it's like there's a big event. Oh, okay, so now, oh, you're sick, you know, so now we can't go to Disney World, you know, because you're sick. And, you know, it was in one of the discussions that a woman, a female warrior mentioned, you know, that look, have any of you ever gotten that look where, you know, something good is getting ready to happen and then you're getting sick and they look at you, oh, okay, so you're sick again. And man, it was amazing, the outpouring of emotions that came from that, because it seemed that everybody had experienced that, you know. And then we were talking about the asking for help, you know, and just making it clear that, I mean, people talk about how, you know, I don't really want to I shouldn't have to ask for help. You should just help me, you know, and sometimes people don't know what to do, you know, and so really there was an emphasis on the fact that you can't wait for people to give you help. You have to ask for help. And then there's the whole issue of self-care. And, you know, I really feel like with, particularly when we have this peak in mortality at the time of transition to pediatric adult care, and it's why? Because sometimes it's a bridge to nowhere. And our adult patients are getting care in the emergency room and in the inpatient setting. And a lot of times the care that they're getting is not good. So people have to know how to take care of themselves. They have to be so educated. They have to go to Cassandra's webinar, and they have to go to Lakia Bailey's website to learn. You know, there's one thing for sure that doctors need to understand, and that is warriors know their bodies and they need to be believed, and parents know their children, you know. So the idea of all the things that Dr. Savings was talking about, you know, a healthy diet and moderate exercise and so forth. But another really important point is I have warriors tell me that they went to the doctor and the doctor looked them straight in the face and said, I don't know how to take care of you. You know, so there are guidelines, all kinds of guidelines that are going to be talked about. And in my sickle cell patient empowerment toolkit, there's one thing that's there that I think is really important. And that's I give them the CDC guidelines for how to take care. So, hey, doc, here's how you take care of me. I mean, I remember when I was a pediatric resident, I carried around Harriet Lane. You know, people like to have things in their pocket, you know, that they can look at. And the other thing is that you have to be able to advocate for yourself because you know what you need. And I had one of my former patients tell me that she was being admitted for pain, and her hemoglobin was 7 and her retic count was, she asked what was her retic count because they wanted to give her a blood transfusion, and her retic count was 20. And she said, well, my pediatrician taught me that a blood transfusion is not the proper treatment for a person with sickle cell disease who's in pain. It's not going to do anything for my pain. And all you're going to do is expose me to all the risks of a blood transfusion and none of the benefits. So, you know, self-care is just, and self-advocacy is really important. And that was one of my proudest moments, to have one of my patients be able to prevent getting some care that was really inappropriate for her. And I also just want to mention the impact that the sickle cell disease, you know, it impacts the entire family, not just the warrior, and particularly the parents. And I'm going to go back to newborn screening when I call the family and tell them the child has sickle cell disease. And there's this tremendous guilt that, oh my goodness, I gave my baby something that I didn't even know that I had, you know, and that guilt can really lead to overprotection. You know, to just really getting crazy about, oh, you can't do this, you can't do that, because I just really have to protect you and I have to treat you differently from the other kids because you have sickle cell and all of that. And so, you know, I don't know how to mitigate that guilt. But one of the things that I say to mothers pretty routinely, and to parents and fathers pretty routinely, is, do you think your child was supposed to be here? Do you think your child has a purpose here on earth? You know, and another thing that happened at a support group meeting was that it was suggested to me that when I wanted the topic of discussion to be, what was the biggest negative challenge that you ever had with sickle cell disease and how did you overcome it? And it was actually Tiana Wolford from SC Red that suggested to me, well, Dr. Shurney, why don't you ask them what positive things have come from the fact that they have sickle cell disease? And when I brought that up, first, you know, our initial meeting was virtual, and just the looks on their faces like, Dr. Shurney, what are you talking about? The positive effects, you know? And so then, you know, one warrior chimed in and said, you know what? I'm very resilient. You know, I am strong. I am, you know, and then we went around the room and everybody had something positive to talk about, how sickle cell disease made them who they are. You know, and then the other issue that was interesting for me for that was, I remember talking to a very young warrior about bone marrow transplant. And she looked me straight in the face and she said, well, Dr. Shurney, if I don't have sickle cell disease, then it's no longer me. I mean, no, I don't want to transplant. Sickle cell is a part of me. And I went home and like, wow, that was really strange. But now with this potential for a genetic cure and bone marrow transplant, people are talking about, what does it feel like to not have it anymore? And who are you? And what is your identity? And then you get kicked out of the sickle cell clinic, and then there's survival guilt. So this whole impact thing is really, really huge. So, I'm going to end by saying that it takes a village to care for a sickle cell warrior. And that was the theme for our last walk. And I'm glad that everybody here on the call is a part of the Sickle Cell Village. So with that, I'll stop. And if people have any questions, or I don't know whether questions and answers are going to come later, but I will stop sharing my screen. And I will tell you that I have another talk to give at 1 o'clock. So I will stay on until lunch. And then, so if there are questions that come up for me after that, if the organizers can just share those questions with me, then I'll be happy to answer them. So that's it. What do you think?
Thank you, Dr. Shurney. Appreciate it. I think we're going to have questions in the chat or the Q&A section.
Okay.
We don't see any currently right now. And like you mentioned, Dr. Whitten-Shurney, we will share that with you if we get any afterwards.
So I see that Etta Carter has her hand raised. Or does that mean I don't think that the participants can unmute, so she would have to put her question in the chat, right?
Yes.
Okay. All right.
Okay.
So I see, where can you get that shirt? So I'm gonna put, yeah, this is the shirt, Hope. Let me show you the whole thing.
That was the shirt. It was the shirt from the presentation.
Oh, the Sickle Cell Matters shirt? Okay.
The one that, like, I am in pain. That one. My pain.
Okay.
My pain. That
Okay.
is that I think is very. I'm an ER doc. It was very relevant for what I do.
Okay, I am going to put my email address in the chat. And then you can let me know. Shurney. Okay, I'm done.
I want to say that was an excellent talk. I'm going to be stepping away from my computer. So.
Okay. Ooh, I'm looking in the chat. I think I went over a little bit of time. I'm sorry. How bad did I do, Beverly?
You're fine. Thank you so much. That was amazing. Thank you very much for being our keynote. And I'll hand it over to Ryan to introduce the next speaker.
Thank you, Beverly. Hi, everyone. My name is Ryan Cooper. I am one of the members of the Community Advisory Board, and I am honored to formally introduce the speaker of this portion of the session, Dr. Lewis Su. Dr. Su is a professor of pediatric hematology at the University of Illinois at Chicago and has a career focus in sickle cell disease. His MD PhD training was completed at the University of Rochester, his pediatric residency at Yale, and his pediatric hematology oncology fellowship at Children's Hospital of Philadelphia. He is a volunteer chief medical officer for the Sickle Cell Disease Association of America and has 29 years of leadership and experience in the US for sickle cell disease programs. His early research examined sickle cell lung disease using mouse models. He has joined landmark studies of stroke prevention and hematopoietic stem cell transplant. His current research uses implementation science to improve sickle cell care. In the US, Nigeria, and Brazil, he is developing health education to empower families to overcome the complexities of sickle cell disease. Once again, I'm going to turn it over to Dr. Lewis Su.
Thank you, Ryan, for the formal introduction. I appreciate
Of course.
Dr. Su, do you want to share your own slides?
Yes, please.
You're welcome to. Or do you want me to share?
Oh, you're going to share? You please.
It's up to you. What
Please
you-
go ahead and share.
Okay.
So the title of this talk is Guidelines, Where Are We? And the general idea is going to be to just flash on the screen fairly quickly several sets of important sickle cell guidelines that are evidence-based and very current. I don't think any of the guidelines I'm looking at is more than a few years old. Next, please. And then we'll go through acute chest syndrome as one of the examples for what kinds of things to do. These are my disclosures. I do some research, I do some consulting. I'm going to talk only about things that are approved indications for medications. Next, please. So the first guideline I'm going to talk about is that for the United States, the diagnosis of sickle cell is basically made through newborn screening. And for the state of Illinois, for example, the guideline would be in the Illinois Newborn Screening Practitioner's Manual, which emphasizes that all babies are screened, no matter what your name is, no matter what color you are, you're going to get screened for sickle cell. And then if there is sickle cell detected, as Dr. Wanda Whitten-Shurney was discussing, notification of the family with the goal of trying to start the preventive penicillin by 2 months of age. And this is a public health goal. This is a medical goal. This is like the bedrock, the foundation for sickle cell care in the United States, because without that diagnosis, then all kinds of bad things could happen that could have been prevented. And pretty much we're attributing most of the improved survival of individuals with sickle cell disease to newborn screening. So all across the world, newborn screening is the guideline that people start with. Brazil, Nigeria, Tanzania, Malaysia, India, they're all trying to do newborn screening. Next, please. The next big guideline for people to be aware of is that the National Heart, Lung, and Blood Institute, NHLBI, which is a unit of NIH, has been releasing guidelines for sickle cell over the course of probably 2-3 decades. But the most recent one was 2014, and then they basically said they're going to stop. We talked to the NIH recently. They're not planning to put out any more guidelines. They've gotten out of that business because they've handed it over to the American Society of Hematology. And so the latest sets of guidelines that we can refer to is NHLBI 2014 as a federal guideline about the standards of care. And then American Society of Hematology is a way to very conveniently access that. So there's a free app that you can have on your very own phone in your pocket if you want to see NHLBI 2014 guidelines. Next, please. Yeah, it's called ASH Pocket Guide. And then just so you see it again, ASH Pocket Guide. The ASH Pocket Guide also has 5 guidelines on specific topics. So cardiopulmonary and kidney, cerebrovascular, so brain, pain management, stem cell transplant, and blood transfusion. These guidelines were each written with the help of experts in hematology plus other conditions. So you can imagine for like cardiopulmonary and kidney, they had kidney specialists and heart specialists and lung specialists in addition to the hematologists. Plus, each of these guidelines writing committees had individuals with sickle cell disease at the table. So remember, you heard about how Dr. Lakia Bailey says nothing for us without us. For this, people with sickle cell were at the table, including Ronisha Edwards-Elliott, who was on screen just a little while ago. She was part of one of these national guidelines efforts. And you can see all these in your ASH Pocket Guide app in a very convenient boiled down form. If you want to see the full publication, you can go to this website. But these are the most recent things that we have. And so if you're trying to get for medication approval, trying to avoid a malpractice suit, if you want to know as a patient what you're missing out on, if you're not going to a sickle cell specialist, these would be some of the places to find out. Next, please. How about the emergency department? During COVID, this has come out, the ASAP point of care sickle cell toolkit. And so this is an app and also a website that says, if somebody with sickle cell disease comes to your emergency room and you don't happen to know what you're doing, or you know what you're doing, but you need a reminder, this is a way to step-by-step go through the acute management for sickle cell to see, okay, here's my patient with sickle cell. Do they have pain? Yes, no. Okay, I'll do this. Do they have fever? Yes, no. Okay, I'll do that. Do they have respiratory problems? Oh, maybe I got to get a chest x-ray. Oh yeah, the algorithm says that. I'll do that. So this walks somebody through at least the initial management so that it can be done fairly swiftly in an evidence-based way, not forgetting things. And then it also has very nice places where it says basically call for a consult. This is extremely current. The last update of it that I could see 5 months ago, and they're going to continue to update that to keep it on point. ASAP point of care toolkit. Next, please. What if you're in the hospital? If you're in a hospital, such as a community hospital, often it would not be a sickle cell hematologist seeing you, it'd probably be a hospitalist. And so the Society of Hospital Medicine, SHM, put out this guide, basically also during COVID, I think it was 2021 or 22, called an implementation guide. And in here, this website has modules for the imaginary hospitalist who wants a refresher on what is sickle cell, what do I do? And then they have a very cool part where they have a quality improvement program to say, hey, here's the bar you're trying to reach. Here's the target of how good the sickle cell care should be. How do I implement that and how do I check it? So we have to just get people to volunteer to go to this website and undertake those tasks. But the tools are now there online, free of charge. Next, please. What if you're a nurse? Well, there's some nursing standards described here from American Journal of Nursing 2019. Our good friends, Dr. Paula Tanabe, Dr. Mary Houlihan. From a nursing perspective, what are the major health complications of sickle cell? What are the nursing implications of each one? And it also has online links as resources for clinicians, patients, and caregivers. What I'm told is that you could get continuing education units for just going through this article and answering questions. American Journal of Nursing 2019. Next, please. What if you're going to school? You are at the school taking care of a student who has sickle cell disease, or you're about to send your child to school and you want to send some paperwork. Well, this website from Children's Hospital of Philadelphia has a whole bunch of stuff. I think there's more than 20 links in there with templates for 504 plans, which is physical accommodations for what the school could do. Allowing somebody to have a water bottle, let them go to the bathroom when necessary. Maintain warmth, have a, if they have a school uniform, allow somebody to have the long sleeve version sometimes and the short sleeve version underneath in case they need to take it off. Individualized education plan templates, tips for college and career, and caregiver checklists. So if you are the parent, the caregiver sending your child off to school, what kinds of things you want to make sure you don't forget. And then there's action plans that go all the way from daycare through college and athletics and aftercare and summer camp, all blended in there. Lots of resources. Very current, 2020 or so. Next, please. What if you're the employer or you are a person with sickle cell going to work? Did you know there's job accommodations listed at this website, askjan.org? This is not a federal organization. It's some sort of quasi-federal agency. But they use the ideas of the American with Disabilities Act. They built in different kinds of accommodation ideas, situations, and solutions to help the person with sickle cell be able to have some accommodations in their workplace. Next, please. And then what if you are just thinking about all the rest of your life, not at school, not at work? What kinds of things could you do to maximize function? Do you need some tips? Well, you could talk to doctors like us, nurses, social workers, other people. You could talk to another person with sickle cell disease, find out what they do. But in case you wanted to search late at night, or you're all by yourself and you're just with your device, there is a CDC website with different tips and steps that talk about maximizing function, stretching, hydration, mental health types of issues. These are not going to replace talking to medical care providers, talking to a community, but they are out there too. Next, please. So now we've got those covered, and you know where to look up stuff. Let's talk through a case possibility. So suppose we have an 8-year-old girl with influenza, and she got started with the anti-flu medicine, also called Tamiflu. She's been on it for 2 days, but she still has pain in her bones. She's struggling to breathe, and she's unable to walk because of her leg pain. What are you going to do? If you don't have any idea what to do, you can go to some of these websites and figure out what to do. Next, please. So what we're talking about is that this probably is going to be acute chest syndrome, ACS, which is the second most common cause of hospitalization and a leading cause of death in sickle cell disease. This is a child, and the highest incidence of acute chest is in children. And if you look up some of this stuff, it'll also talk about how the chances of having acute chest syndrome is different. If you have the SS type, it's higher than SC type or S beta thal type, but it's still definitely there. Next, please. And acute chest syndrome, you'll see in some of those guidelines and discussion, comes in different levels of severity. Shown here is kind of a pyramid, that the most common are mild, but it can get to be more moderate or severe, and that this could be different levels of care depending on what kind of things you've got. But the severe could truly be life-threatening. Pneumonia in a sickle cell patient equals acute chest syndrome because you have a positive chest x-ray finding. Chronic hypoxia, just walking around with an always low pulse ox, is not acute chest syndrome, and some of the guidelines will continue to define that. Next, please. And so what you do for treatment is also defined in some of these guidelines, including the ASEP emergency ones, the hospital ones. We're talking about if it's mild acute chest syndrome, where you meet the definition, but not too ill. This could be a child who's got a fever, has a chest x-ray that shows something, but is literally jumping on the bed. Or it could be somebody who has got some cough and is kind of not feeling that well, but they're still out and about. They want to be able to move around and do activities. What there is for management describes, as Dr. Kay Saving did, multiple different things to try to treat different possibilities that can lead to this acute chest syndrome. Watch out for infections, give antibiotics, adjust your IV fluid so you don't flood somebody's lungs out. Give pain management so that people get enough pain relief that they can breathe deeply, but not so much that they're sedated and can't breathe deeply. So you have to get it just right. If they have asthma, you have to optimize their asthma medicines, and especially inhaled steroids, not necessarily systemic steroids. Send blood bank specimen, get ready for possible transfusion, give oxygen if needed, but also watch closely for worsening. Next, please. So what if it gets worse? Next slide. So getting worse might be now the person needs oxygen. And so if oxygen is needed, or if the shortness of breath is getting worse, the guidelines will say this is the point where you probably want to transfuse red cells and you probably want to get some more consultations. Next, please. Because you don't want things to go further worsening to severe. And severe would be somebody who's basically in the intensive care unit, oftentimes need to be on a ventilator, look just like somebody with the most severe COVID or something like that. And then you're throwing every treatment you have including exchange transfusion, sometimes other therapies that are used for acute respiratory distress syndrome. Pulmonologists might need to go reaching into the lungs with a bronchoscope. You might have to watch out for blood clots and things. And so this is where things are life-threatening. Severe acute chest syndrome, this is where you don't want to be. But if you have severe acute chest syndrome, the place to be in the hospital is the intensive care unit. Next, please. There are medicines to try to prevent you from getting to this point. So now these are a listing of the 4 disease-modifying medicines for sickle cell that are approved by FDA. Shown here, hydroxyurea, glutamine, voxelotor, crizanlizumab. Each of these has some role in possibly reducing the rate of acute chest syndrome, so they're kind of preventive. And it turns out the one that's most effective in preventing acute chest syndrome probably is glutamine. Next, please. But hydroxyurea is certainly our oldest anti-sickling medicine. There's guidance here in some of those guidelines about how to give the hydroxyurea. If somebody has, for example, had acute chest once or twice, we probably will want them to be on hydroxyurea. And here would be opportunities shown with the asterisks for the hematologist and the primary care doc to collaborate and have partnership in how to manage the different aspects of hydroxyurea. Next, please. There's also things for the primary care doc and the hematologist to try to avoid some of these guidelines. We'll talk about that. You want to probably avoid giving a steroid pulse like you would for asthma without sickle cell, because there can be this rebound of acute chest getting worse after the steroids come off. So you want to try taper the steroids. There's also pitfalls of underdosing the analgesia, where somebody doesn't get enough pain medicine, their chest is still hurting, they're not taking deep breaths, that's probably going to make their acute chest worse. And so the guidelines talk about that too. Next, please. Transfusion, as was mentioned, transfusion is something to do very carefully in people with sickle cell. The need for transfusion, shown in the left-hand column, could include moderate acute chest or acute low oxygen. Sometimes you need to have regular transfusions, shown in the right-hand column, and it might be if somebody has repeated rounds of acute chest syndrome. I have one child who's had 6 episodes of acute chest syndrome, and so we put her on a transfusion program. She's gone a year or 2 without acute chest. Next, please. But transfusion could cause harm, as Dr. Farooqui had mentioned, with antibodies, with iron overload. There is also transfusion-transmitted infection is possible. And then during COVID or any other time, there's a limited supply of blood. And so we can't just use up everything, because the next person who needs a blood transfusion may not be able to have it. So this little sign is supposed to be a caution sign. So we tried to be very scrupulous about when to do the transfusions. Next, please. And then finally, acute chest prevention. There's other guidelines to talk about how one of the ways to prevent acute chest is to get vaccinations, annual flu vaccine. This is the season right now to get your flu vaccine. I got mine yesterday. Literally, I still have the Band-Aid on. Avoiding atelectasis and doing incentive spirometry, getting out of bed, optimizing your asthma care, and then doing things like avoiding same-day surgery, getting anesthesia, and then going immediately home in somebody with sickle cell could be hazardous, could lead to acute chest syndrome. And so we usually admit somebody after anesthesia. And so that's some of the guidelines that talk about that too. Next, please. That's a picture of the incentive spirometer. So what happened to that case that I mentioned to you? This actually was a girl who was a migrant at the Texas border. And she first was diagnosed with influenza. She got treated with Tamiflu, with the oseltamivir. But over a couple of days, she did develop these symptoms: pain in her bones, struggling to breathe, and unable to walk. And the mother, who was pretty well informed about sickle cell from Honduras and Panama, kept asking the Border Patrol folks, please, my daughter needs to go to the hospital. They can't just be in the Border Patrol infirmary waiting to see how things will go. She needs to be in the hospital. She has sickle cell disease. Send her to the hospital for sickle cell disease. And she's in Texas already. She's not out on the road somewhere. She's actually in Border Patrol. But they didn't. They didn't open the guidelines. They didn't do that. Next slide and hit the advance. And unfortunately, she died in Border Patrol custody of acute chest syndrome. So failure to follow guidelines can lead to very bad outcomes, even when you're very close to be able to getting the care that you need. So we really want to try to publicize these guidelines. Next, please. So having the guidelines is best practices, it's evidence-based, it's also a matter of health equity. And having more things like this will help us to eventually develop better treatments, more cures, more information. But we want to make sure that people are at least getting the standard of care. And that's a health equity kind of thing. I will stop there. Try to open my Q&A thing, see if there's anything there.
Don't see anything in the question and answers or in the chat right now.
Okay, people want to just get to lunch.
I think so. So I guess we'll take a lunch break and be back about 12:45 to start Dr. Njoku's talk.
Sorry, I have a question. Dr. Su, you mentioned that so day surgeries are not advisable. So what kind of these types of surgeries that, you know, patients should be really careful and tell providers or advise their providers about in terms of if they could be observed a day after the surgery?
Yeah.
Some examples of them. I don't know if a
Yeah.
colonoscopy fits one of these, or is there any other procedures that they can think
Right.
about?
Thanks for the question. So I think there are gradations, categories of surgery that sort of go minor, moderate, and major surgery. Major surgery being things like brain surgery or heart surgery that you have to be in the hospital for that. But there's some moderate surgeries like scopes and so forth, where some people might have been thinking of day surgery, and the one for pediatrics has been like tonsils, adenoids, sometimes port placements, these kinds of things where you're actually under anesthesia. That is the one, and especially the ones that have to do with your airway. Pretty much those should be admitted afterwards. There's categories of minor things, which would be things like putting in ear tubes, piercings maybe, or things where you're not actually completely asleep, you're just getting sedated, you're not under general anesthesia. Those could be entertained as possibly things for day surgery, but probably should be done in some kind of consultation for the rest of your condition. So if you have a chronic lung problem or some other chronic organ problem, that could add to the risk, and it still might be worthwhile to get observed after the procedure.
Can I ask, is this the same for pediatrics as well as for adults? And then what about SC disease versus SS?
Yeah, so it would be that there's general categories that span across different age ranges because it's the type of procedure, like a spleen surgery or gallbladder surgery or tonsil surgery. I think that for the other parts, you pretty much need that case-by-case discussion.
Okay, because I'm
Somebody
thinking,
with SC could have very mild issues or could be pretty severe. You can't just say because of SC, you can decide this.
what about something like an arthroscopic surgery?
Yeah,
Or
I think
joint?
that depends on how long it's going to be, what kind of anesthesia they're going to do, and what the overall physical condition is person. So individual.
Thank you.
Yeah.
So this is Dorinda. I have a question.
Yeah.
So Beverly just mentioned the colonoscopy, and then since we were talking about earlier with the sickle cell warriors that are aging gracefully, that are not NPs, when you're considering things like your colonoscopy, is that something that should be
I'm
also?
gonna see if I can call a friend here. Is Dr. Farooqui there? Or Dr. Insia, some other adult doc?
Yes, I'm here.
What would you recommend?
What's
Do
your
you have a
question
routine
again?
recommendation for colonoscopy?
So basically in our patient population, like in the adults with sickle cell disease, majority of the time the recommendation is if someone who has a genotype of hemoglobin SS or S beta not, which is in general considered more severe types, the recommendations are any procedure that would require anesthesia for greater than 20 minutes or 30 minutes. Essentially, they are the individuals at higher risk. And depending on that, their hemoglobin, I think those are the ones who should definitely be in the hospital and monitored more closely. Whereas simple procedures, just like how Dr. Sue mentioned, like maybe a small skin biopsy, or any of those kind of procedures, for those reasons where you don't require any anesthesia, you don't have to observe the patient for long. I hope I've answered your question.
Yes, thank you so much.
Right, thank you for that too, Dorinda, because I'm thinking if you had a colonoscopy and you're going to be in twilight and you had a polyp or something like that and you had to have that, excised, and you maybe have SC disease. So you still recommend that you not do that procedure just in the day surgery, or?
Yeah, so basically, as I said, essentially the whole concept is, and the reason why we want to monitor these patients for longer is your body gets into a stressful situation when you're undergoing any surgery. And with that being said, there are higher chances for you to go into vaso-occlusive crisis and even to develop acute chest syndrome for all that sedation. So that is primarily the reason why we want to monitor these patients for at least a day, I would say.
Okay.
Thank you.
This is really good to know. Thank you very much.
Thank you, Dr. Insia.
And I would like to add one thing in, since we're discussing this. So the recommendations are majority of the time we should ideally bring their hemoglobin higher too. And the goal would be somewhere between 9 to 10 prior to the procedures, because this, like many researchers have shown, specifically for patients who have hemoglobin SS or S beta not, that once their hemoglobin is brought to these values prior to the procedure, their chances of developing acute chest or vaso-occlusive crisis post-operatively goes down drastically.
Really? Okay.
And that also is with these gradations of minor surgery, probably don't need to, but moderate or severe, big
Exactly.
surgery, yes. Right.
Well, one more question then, that opens up another question then, is how is your insurance going to look at that? Because, for example, when I have my colonoscopies, I do it in my local hospital, I do it in day surgery. And I've had polyps, they're benign, I've had those be removed, and I go home and, is my insurance going to say, I was doing this way, are they going to pay for me being hospitalized? How do I convince somebody that I need to be hospitalized or monitored? Well,
and we're trying not to get into individual healthcare, but what we're just quoting was that these are national guidelines. These are the standard of care. And so if the insurance is failing to pay for the standard of care, you have a huge case.
Really?
Thank you so much, Dr. Sue and Dr. Rizvi. We have 2 more minutes for break, and we'll be starting our break time now so that people can rush in, grab something for a snack or move around and drink water. Thank you so much. Okay, thank you, everyone. We will start our second session, emerging care, medicine and treatments. And I will hand it over to Patricia Leslie to introduce our next speaker.
Good afternoon, everyone. Our first speaker is Dr. Franklin Njoku. Dr. Njoku is an internist and director of the Acute Care Center in the Sickle Cell Center at UI Health. He attended medical school at the University of Nigeria and completed his residency at Cook County Hospital in Chicago. Dr. Njoku's interests are increasing the longevity of individuals with sickle cell disease. Thank you, Dr. Njoku.
Thank you, Patricia, and hello, everyone. Like Patricia said, I'm an internist and also a geriatrician with the UI Health Sickle Cell Center. 4 years ago, I thought I could bring my experience treating debility and frailty and chronic organ damage to our sickle cell population. So I joined the Sickle Cell Center, and I've been enjoying it since then. So, Patricia, are you going to share my slides, or should I share it? Thank you very much. So my topic today, can you go back to the initial slide, please? Initial one. So I'll be talking about new medicines in the sickle cell provider toolkit. And despite the topic, next slide, please. I have nothing to disclose. Next slide. So I was going to say, despite the topic new medicines, I'm going to be dwelling a lot on many of the clinical agents we're already familiar with. And it's relevant to keep talking about them because many times it could be confusing who gets what. But I'll also be talking about important compounds and molecules that are currently undergoing clinical trial and have shown promise. Next, please. I want to apologize for my slides. They might not be adapted to a mixed audience. I don't know what I was thinking. I don't see the entire slide. Patricia, can this be adjusted so I see the entire slide? Is it possible? All right. So
Beverly is running the slides.
I'm running the slide. What part don't you see?
The bottom is cut off. But I can just talk about what I see currently. So when you're looking at this, let's go from A clockwise down to D. So what I want to talk about is the multiple biologic targets in sickle cell pathophysiology. So this slide kind of shows the pathological process in sickle cell disease and where we can possibly intervene with therapeutic agents to mitigate the severity of the disease. So in the A panel, we see hemoglobin polymerization. And polymerization, what it means is this, that the individual particles of hemoglobin, and there are just about 200 million hemoglobin particles in each red cell, and they're floating around in the cytoplasm. But in sickle hemoglobin, when they lose oxygen, they could stick to one another and form polymer bundles, like we're seeing here. So in the polymer bundles make the sickle RBC to sickle. And when we see the panel B on this slide, when the red cells sickle, they become really sticky and they have the potential to stick to the walls of the blood vessel that they are transiting through. And that stickiness would occlude the tiny blood vessels and causing ischemia of the distal portion of the blood vessel. And sometimes this ischemic cascade dislodges and flow is reestablished, causing ischemic reperfusion injury that leads to sterile inflammation in panel D. So when we go back to A and go counterclockwise to C, so what you see is that polymerization could also lead to hemolysis. And what hemolysis means is the red cell membrane just busts open and releasing hemoglobin into plasma. And cell-free hemoglobin is really toxic to the surrounding tissue. So it leads to endothelial dysfunction. Endothelial is the lining of the blood vessels. It depletes a lot of molecules that the endothelium is already producing to keep itself in shape, and leads to damage long term. So what happens is, at every point of this pathophysiologic process, there's a potential to develop therapeutic agents to interrupt or mitigate the severity of the disease. At the level of the DNA, gene therapy and stem cell transplant tries to nullify the mutant hemoglobin S and get us back to hemoglobin A, or at least hemoglobin F, that doesn't sickle. And if you come to the level of the protein, hydroxyurea, the site being THU, could help increase the production of hemoglobin F that helps to reduce polymerization and sickling. And we also have molecules that increase the affinity of the sickle hemoglobin for oxygen, so that the sickle hemoglobin is not giving up all its oxygen and thereby sickling. So we have voxelotor, GBT601, etavopivat, mitapivat, all of these increase hemoglobin S affinity for oxygen. And beyond polymerization, at the level of the vessel, we have adhesion modifiers like crizanlizumab, inclacumab, rivipancel, and all of this can help reduce adhesion and vaso-occlusion. And when you come to endothelial dysfunction, you have vasodilators like riociguat, Imara 687. These are molecules that have shown promise with improving endothelial dysfunction and restoring nitric oxide balance at the level of the endothelium. NAD substrates like arginine, L-glutamine also helps to mop up reactive oxygen species that we see after hemolysis. Next slide, please. Next slide. Now, if we go to the individual clinical agents, many of us are familiar with hydroxyurea. We've had the longest experience with hydroxyurea. It was FDA approved in 1998. So it's been around for close to 25 years. Very important medicine to treat sickle cell disease. And it's standard therapy for sickle cell anemia, that is hemoglobin SS and sickle beta 0 genotypes, after 9 months of age. Keep in mind, in 2017, the FDA expanded approval to include children with sickle cell disease. So after 9 months of age, many clinicians would place sickle cell anemia individuals on hydroxyurea. But for the traditional mild or moderate genotypes, we don't have as much data supporting that they have excellent outcome with hydroxyurea. However, when the moderate genotype of hemoglobin SC or sickle beta plus starts to show severity like SS or sickle beta 0, it's standard practice to also start them on hydroxyurea. And the primary action is hemoglobin F induction. So it increases hemoglobin F, and hemoglobin F kind of stops polymerization, because if you have hemoglobin F interspersed with sickle hemoglobin, polymerization doesn't happen as much. Additional actions include it decreases markers of adhesion and improves endothelial function. Clinically, it reduces the frequency of vaso-occlusive episodes, acute chest syndrome, transfusion rate, hospitalization, transcranial Doppler velocity that predicts stroke, and it decreases mortality and healthcare costs. It's important to also say that hydroxyurea is safe. It's very safe, and for most patients, they do tolerate this medication very well. It does not cause cancer. Next slide, please. Let's talk about L-glutamine and Darin, which received FDA approval in 2017. It's a conditionally essential amino acid, which means its level increases. The level of L-glutamine increases with when the conditions are met, when in stressful conditions, for instance. And L-glutamine is essential for synthesis of NAD. NAD and the reduced version NADH, they're important in helping to mop up oxygen radicals seen at the level of endothelial dysfunction, like we saw in the previous slides. So next slide, please. So this is the clinical trial that informed us of the efficacy of L-glutamine in treating sickle cell disease. So in this phase 3 trial of L-glutamine, we see in the first Kaplan-Meier curve that there's a 25% reduction in number of painful crises and intensity in individuals taking L-glutamine compared to placebo over a 50-week treatment period. And on the right-hand side, you see curves that show that the time to the first sickle cell crisis is prolonged. It's about 84 days for L-glutamine and 54 days for placebo. But even more dramatic is the time to the second crisis. So in individuals who are taking L-glutamine, the crises are less intense, the crises are less frequent. So it's it's an effective agent for patients who get on this and find themselves adherent to the treatment. Next slide, please. So the next one we'll talk about is oxybrita or voxelotor. So voxelotor is a hemoglobin S polymerization inhibitor. So it prevents the sticking together of hemoglobin S molecules to form polymers that result in sickling. And a once-a-day oral administration of voxelotor has been shown to reduce red cell sickling, blood viscosity, and improve red cell deformability in vitro, and also extend red cell half-life and reduce anemia in vivo. So next slide, let's look at the trial, the voxelotor trial. So the initial HOPE trial of voxelotor in sickle cell disease looked at the effect of voxelotor over a 24-week treatment period. But these charts here are showing data from the long-term follow-up of these individuals for 72 weeks. So in individuals who were on a standard therapy of voxelotor, which is 1,500 milligrams. We know that 1,500 milligrams is the standard dosage. So you, in individuals who were on the standard dosage of 1,500 milligrams, and these are adults, about 90% of them actually achieved a more than 1 gram increase in their baseline hemoglobin. That is, if they started at 8 grams of hemoglobin, after 72 weeks, they were at 9 grams. 90% of them. If you look at the proportion that achieved 2 grams, it's almost 60%, as compared to only 3.3% in the placebo group. And the proportion that achieved 3 grams, which is substantial, which is actually really significant, very good. So 20% of them achieved more than 3 gram rise in hemoglobin. And when someone has sickle cell anemia with very low steady state hemoglobin, every gram increase counts. Every gram increase results in mitigation of disease severity and reduction in side effects, in chronic complications in the long term. So let's look at the panel B and C. What it shows here is, in comparison to the placebo group, the voxelotor standard therapy group had an average hemoglobin rise from baseline of 8.6 had up to 9.9. That's average. But if you look at the peak they achieved, the highest hemoglobin was up to 11 grams. And this is significant. So voxelotor, in summary, is good therapy for people with sickle cell disease who have low steady state hemoglobin, especially the individuals with sickle cell anemia, SS, and sickle beta 0. Next slide, please. So this is a sister molecule. We have GBT021601. It's a hemoglobin S polymerization inhibitor that's still under clinical trial. So it's just like voxelotor, but what it does better actually is it has what we call, so compared to voxelotor, this molecule has potential to achieve higher hemoglobin occupancy. So what you possibly need a smaller amount of the compound to achieve the effect of voxelotin. Therefore, it's likely to reduce pill burden amongst our patients taking this pills. So it's still on that clinical trial. Hopefully it comes into mainstream and those individuals who qualify can start using this clinical agent. Next slide, please. So here we look at the addition, cell addition inhibitors. So in addition to anti-sickling therapy, targeting cellular adhesion downstream provides a novel, powerful therapeutic option for clinical management of sickle cell disease. The selectin and selectin ligands expressed on the endothelium. If you look at the right-hand side, on the right-hand side chart, the left-hand side of this chart shows the ligands attached to the white blood cells and the endothelium and the hematopoietic stem cells. And you see all these ligands interact with one another during a vaso-occlusive crisis, and we'll see how they do that. So what happens is the cell addition inhibitors can stop this interaction in real time. Let's look at the next slide, please. So here you see how the white blood cell with its ligand, the PSGL1 ligand, tries to bind to the P-selectin ligand on the endothelium. And the white blood cells, they're not innocent. They are the instigators of vaso-occlusion. You let them bind to the P-selectin on the endothelium, and what happens next? They create the vaso-occlusion cascade. So what crizanlizumab does is it goes to interrupt this interaction between the P-selectin ligand and the endothelial surface. Remember, the endothelium is covering the blood vessels, and the white blood cells are flowing through the blood vessels. They shouldn't bind to this ligand on the endothelium, because when they do that, they create the vaso-occlusion cascade. And crizanlizumab obstructs this interaction and resolves vaso-occlusion. Next slide, please. So what we see here is the sustained trial that informed us of the efficacy, the clinical efficacy of crizanlizumab in treating individuals with sickle cell disease. In this trial, about 65 to 67 patients were placed in 3 different groups: the high-dose crizanlizumab, the low-dose crizanlizumab, and placebo group. And they were studied for 52 weeks, getting infusion of crizanlizumab with the primary outcome of the rate of pain crisis. So at the end of the study, the primary outcome of reduction in acute pain crisis is shown on the charts on the right-hand side. So we see that the high-dose crizanlizumab group achieved a significant reduction in pain crisis in comparison to the placebo group. So at baseline, these individuals had 2 to 10 pain crises per year at baseline. So, but the high-dose crizanlizumab participants had an average number of pain crises of 1.6 as compared to 3 pain crises for the placebo. And when you look at the secondary outcome, which is the chart below, the secondary outcome is actually more dramatic because the time to the first crisis was significantly longer than in placebo. And when you're looking at the time to the second crisis, it becomes even more dramatic. Next slide, please. And crizanlizumab has also found very important use in the treatment of priapism, a very troublesome symptom and complication of sickle cell disease in our young males. So this is a preliminary analysis of the Spartan trial. In individuals, in young males with priapic events, they were enrolled in this trial, about 24 of them. They went through a screening period of 12 weeks during which they recorded the number of priapic events they were having, after which they went through infusion of crizanlizumab to see who gets benefit from this infusion. And what we saw from this analysis is that the higher the number of baseline priapic events, those who had greater than 22 baseline priapic events actually saw a more than 60% drop in the number of priapic events they had at the end of the follow-up period. And this was a significant improvement. So this pattern trial analysis, the final analysis is yet to be done, and we look forward to it. But many clinicians already have started using crizanlizumab to improve periapic events in our young males with sickle cell disease. Next slide, please. Here we look at another sister compound to crizanlizumab called inclacumab. And inclacumab is still in clinical trial. But what we expect from this medication is beyond crizanlizumab, it has a very long half-life of about 84 days. So what it means is that you will be able to infuse this medication maybe once every 3 months, such that a patient can get 4 infusions a year and be free from painful, very severe painful crisis. So hopefully it lives up to the promise when the final analysis is done. Next slide, please. Here we go to another group of agents under clinical trial, the pyruvate kinase activators. So the pyruvate kinase activators, what they do is to reduce the level of this molecule called 2,3-DPG. 2,3-DPG is it's produced when there's a lot of anaerobic glycolysis. And again, I don't want to go into dense medical description. So what happens is 2,3-DPG is very prominent in severe anemia, like in sickle cell anemia. The more anemic patients are, the more 2,3-DPG they produce. And there's a biologic reason for that. The body wants hemoglobin to give up all the oxygen it's carrying, and 2,3-DPG forces hemoglobin to give up oxygen to supply the tissue in anemic states. Unfortunately, the sickle hemoglobin, if it gives up its oxygen, what does it do? It then polymerizes and leads to sickling. So we don't want it to give up all the hemoglobin, all the oxygen it's carrying. So pyruvate kinase activators activate pyruvate kinase and divert the production of 2,3-DPG and increases ATP production, which is very relevant. So with reduction in 2,3-DPG, we have the sickle hemoglobin keeping back some of its oxygen, just like voxelotor made it do. And what happens is there's less polymerization and sickling. So the agents under investigation include mitapivat and etavopivat. So we'll look at this in the next slides. Next slide, please. So mitapivat is a small molecule allosteric activator of pyruvate kinase. And what it does, like we mentioned in the previous slide, is it reduces 2,3-DPG and increases ATP production. So in the clinical trial that looked at the clinical efficacy of mitapivat, 16 subjects were enrolled in ascending doses of these agents and treated for 2 weeks each. So we see that in the subgroup that received 50 milligram BID dose, there was a more than 1 gram increase in their baseline hemoglobin. And that's about 60% of them responded in this fashion. 60% of those getting 50 milligrams BID had more than 1 gram increase over 2 weeks, which is significant. And there were some side effects, many of them not so serious. Next slide, please. Next slide. Again, in this trial of etavopivat for clinical efficacy, it shows the same promise, 400 milligrams once daily for at least 4 weeks, potential up to 12 weeks, showed a sustained rise in hemoglobin in individuals who were treated with this agent. It also showed a drop in markers of hemolysis, including absolute reticulocyte count, LDH, and indirect bilirubin. Next slide, please. So in addition to the clinical agents we just looked at, there are lots of clinical trials that are going on to try to develop therapeutic agents that could be used in routine clinical use to help individuals with sickle cell disease, because I don't think everyone is going to qualify to get gene therapy or stem cell transplant. And even those who qualify, some people, like our previous speakers, especially Dr. Shurney highlighted that many individuals are scared of the long-term complications of even gene therapy. So it's going to remain relevant to continue developing therapeutic agents that could be used in sickle cell disease to help improve the disease and allow people live life to the fullest, like they want to. So the future holds a lot of promise, and as these trials results, we are going to get more clinical agents for use. Next slide, please. So in conclusion, there are multiple potential biologic targets in the pathophysiology of sickle cell disease for development of therapeutic agents, and there are multiple novel sickle cell disease target therapies already approved and a lot more under clinical investigation with some very exciting results. Next slide. Thank you very much, and I'm happy to take questions.
Thank you so much, Dr. Njoku. We currently do not see any question for you, but if we come up with another questions, we'll definitely send them your way. And I'll hand this over to Patricia.
So I see that Dr. Rondelli is on. Are we making the change in the schedule?
Yes, we are introducing Dr. Rondelli.
Okay. Dr. Sue is going to introduce Dr. Rondelli. But are you there? Okay.
Great, thank you. Thank you very much, Dr. Rondelli. So it's my pleasure to introduce Dr. Damiano Rondelli, who is the chief for the adult bone marrow transplant hematology oncology. So he's over our Sickle Cell Center, and he is one of the international leaders in stem cell transplant for sickle cell for cure for adults, and has been leading that for over 10 years. This talk is about gene therapy, which is the next step for those who don't have a donor for transplant. Dr. Rondelli.
Thank you, Larissa. Thank you, everybody. I have, let me share my slides, I guess. All right. Okay, can you see my slides? Yes, I think so.
Yes, we can.
So my talk today is, about gene therapy, but when we talk about pros and cons, I think we have to discuss about the alternative. And first I want to disclose I'm a steering committee of the Vertex gene editing trial in sickle cell. Obviously, with the survival rate that we all know of in sickle cell, despite the new agents, there's no cure. The treatment that has been developed over many years to cure the sickle cell are mostly an allogeneic stem cell transplant, which we'll see what options it represents. And newer options are gene therapy or gene editing. Now, when I was saying, when we talk about pros and cons, I think it's the comparison between options that will make worthy or not worthy the attempt. So in my next 15, 20 minutes, I'd like to go over the gene therapy data that a summary of the gene therapy data, but also a summary of the transplant data to sort of having like a discussion at the end, which I think is what patients are more interested in knowing, comparing options, what we know and what we want to know, what are the risks and benefits of either one of the two possibilities. Gene therapy for sickle cell disease means basically to make a sickle cell becoming a red cell that doesn't sickle. That can be done in different ways, as I'll show in a second. But basically, genetically modifying a red cells that has mostly hemoglobin S into a red cells that has mostly something different than hemoglobin S, which could be a hemoglobin F or hemoglobin A or basically different type of hemoglobin A or gamma. Two ways to do gene therapy. One is a gene addition, which basically means to transfer a gene into the cell. This is usually done by using a viral vector, lentiviral, adenoviral vector into a hematopoietic stem cell that is taken out of the patient's bone marrow. And by gene editing this gene, for example, a beta globin, different type of beta globin or gamma globin, make the stem cells produce red cells that will be mostly not hemoglobin S. This strategy has been already developed in humans. There has been a clinical trial, a couple of trials done. There's a paper from last year showing that lentiglobin was effective. You see, I don't know if you can see well, but in this slide, you can see the basically the hemoglobin increase in the patient, and the purple bars here are basically gene edited, gene modified red cells. So this is possible. There have been multiple trials being developed with gene addition strategies, utilizing different mechanisms, different mostly lentiviral vectors have been utilized. And all these therapies, as well as the therapy that I'm going to show after with the gene editing, all require the patient to go through a sort of an autologous transplant where the patient has the stem cells taken out, gene modified, and then the patient has to receive a myelosuppression, a high dose chemotherapy to prepare the stem cells that have been gene modified to be infused in the patient without competing with the cells that are already in the patient that are not gene modified. So even if it's an autologous infusion of stem cells, so the cells are from the same patient, there's still like a myelotoxic conditioning regimen or chemotherapy prior to the transplant. And then the patient recovers mostly with the cells that have been gene edited and restores a better hemoglobin or a hemoglobin that is mostly not hemoglobin S. The risk of this trials that there's been issues with these trials because using a viral vector has determined in a few cases where there's been highly suspicious for a secondary cancer related to the viral vector has been utilized, causing unexpected mutations in the stem cells that have caused a few cancer or leukemia or myelodysplastic syndrome. But this has been debated, it's still being discussed whether it's directly correlated, but this actually has sort of put raised a flag on this strategy that are now still being developed further because the technique actually is useful and the patients actually benefit from this. Another strategy is to do gene editing. Gene editing means that we are not adding anything, but actually we are modifying the DNA. The strategy that I'm going to spend some more time on this today, because I'm directly involved in the strategy, is actually by deleting a gene, in particular by deleting the BCL11A gene in the stem cells. BCL11A gene is useful when the baby is born and then switches from the hemoglobin, from a fetal hemoglobin to an adult hemoglobin. So by turning off that gene, we want to restore the hemoglobin F production as in the fetus. Now, this actually is not done, can be done without viral vectors by using electroporation strategies. In particular, the zinc finger and CRISPR technology have been utilized. This actually was published, the proof of concept in a first couple of patients that were actually published a couple of years ago, where this is an example of in a sickle cell patient by CRISPR Cas9 editing of the CD34 cell of the stem cells. The BCL11A gene was actually deleted, and the hemoglobin F was restarted in these adult patients. And you see here in this slide that actually the hemoglobin F, the blue bar, is increasing over time in this patient for a total hemoglobin level of 12. Now, these initial findings have been further exploited in these trials. This is a summary of the two things I told you. And there have been two main trials that have been, they're actually almost completed. And I'm going to talk about the CLIMB SCD-121 trial with CRISPR technology to modify the stem cells and delete the BCL11A-11AB. This is also done, as I said before, by doing an autologous transplant of stem cells with a conditioned regimen with the preparation with high-dose busulfan in the patient. And this actually, the study was presented in multiple meetings recently, and there is now the work is under revision for publication. As I said, through using CRISPR technology, the deletion, the BCL11A gene is deleted, and the cells are pushed to produce more hemoglobin F. As I said here before, the patient, the sickle cell patient, has to be mobilized to collect a high number of stem cells. Now, collection of stem cells in sickle cell, as you probably know, cannot be done with GCSF, which is a standard way that we do in any other transplant. So the patients are mobilized using only Plerixafor, which is a CXCR4 inhibitor that will allow the stem cells to be released in the peripheral blood for 24 to 48 hours. And in that setting, patients are collected stem cells. This procedure can be repeated a few times in order to have enough stem cells that will be then gene edited. And then the patient comes for the transplant, for the autologous infusion of the stem cells by receiving first chemotherapy with busulfan. The cells are infused, and then the engraftment, and then we wait for the patient to restore his counts, his white cell counts, his blood counts, which we'll see about a month after the infusion. And then, so there's no donor involved, and there's an autologous transplant, there's only chemotherapy, but the patient, if all goes well, the patient after that is done. The study actually had the endpoint of the study was actually to look at how many patients were free of pain crisis for at least 12 months after the infusion. And there were initially 35 patients were in this analysis were injected with the cells, and 17 of them were accessible, was evaluable for at least 1 year follow-up for the pain crisis goal. And you see here that these patients were all median, were male and female. They were like actually all of them adult patients, and actually most of them adult patients. As I said, the mobilization with Plerixafor, I'm going to go fast because I want to get to the discussion and see what actually has an alternative. The results actually in the first 17 patients that were analyzed, actually 16 of 17 had no pain crisis for at least 12 months after the infusion of the gene-edited stem cells. And none of them actually had been readmitted to the hospital for pain issues or complaints or crisis for at least a year. In this actually plot, you see here the green bars are the patients after the transplant, and all of them, even the ones with less than a year follow-up, almost all of them, other than one, had not had a pain crisis after the infusion of the gene-edited autologous stem cells. The hemoglobin level in this patient, overall levels were around, this is what it looks like, between 11 and 13. And the hemoglobin F level raised to 40% in these patients and remained stable for the observation time in this analysis. Importantly is not only the hemoglobin fetal level remained stable and the hemoglobin is stable, but also the gene editing. That was a big question. Is the the modification we produce in the red cells, in the stem cells, does it last long time enough to make sure that the results are maintained. So the analysis of these patients, different time points have shown actually that on bone marrow CD34 cells, that the gene editing is persistent, does not decrease. So which hopefully will be a life-lasting event. Patients have all, I'm not going to go into details, but there's been improvement on all the parameters of hemolysis, similar to what we've seen in transplant before. The quality of life parameters that were actually looked into this study also showed a significant improvement at 1 year and 16 months, 18 months after the infusion in all of the patients. The time to engraftment in this setting, though, was a slightly longer than what we see usually in transplant, but all the patient engrafted 26 days for neutrophils and 38 days for platelets after the infusion. There's been discussion on the cell dose, on the effect of the gene editing, but all the patients actually made it safe so far through the transplant. So I think that the take-home message of this study was actually that with CRISPR, that most of the patients actually were pain crisis free at 12 months, and the duration now the current data actually is longer than this, but it will be probably presented, actually will be presented at ASH in December. But all the patients actually have met the secondary endpoint of not being hospitalized for the pain crisis. So it looks like a very successful procedure with no mortality due to the transplant, which was one of the concern. And I skipping the side effects, but there are no major unexpected transplant-related events or mortality in any of these patients. Now, so and this study was done in 15 sites around the world. Now, the alternative to a gene therapy is transplant. As you know, I go very quickly on the transplant because the first message I want to bring is actually we have known about bone marrow transplant in sickle cell for a long, long time. First patient actually was transplanted as a child in 1984, and that actually was a patient with leukemia who had also sickle cell, was cured because of the transplant done for the leukemia. A recent paper that we authored looking at the registry data, so almost 1,000 patients with sickle cell who underwent a transplantation between 2008 2017 were analyzed. Of course, it's retrospective data in the registry, in the CIBMTR registry. And there were a lot of the patients, most of the patients actually had a matched sibling donor, like a matched brother or sister. There were some patients actually had what is now an increasing rate of transplant, a half-compatible donor, haploidentical donor, still from the family. So either a sibling or a parent or a grandparent or some related relative that is only 50% compatible with them. And a smaller proportion of patients actually had a non-related transplant from a non-related donor. The data in the registry include patients from 2008 and 2017, which is in a transplant age, it's a long time. 2008, we were doing a lot of things a lot different from 2017. And I want to say that in 2023, we also have different supportive care therapies, different type of HLA typing. So the data I think is good, but is not as good as in a prospective study that would be done in a top transplant center in the last few years. Anyway, in this analysis of the registry on 1,000 patients, you see that the overall survival was actually over 80% for all the transplants. And the event-free survival was very good for the matched sibling and about 70%, 65, 70% for the other type of transplant. So this is to say that we know the data from transplant. We know when we have long follow-up on a lot of patients, which supports, some of our decisions. I was also part of a panel of the American Society of Hematology to come up with guidelines for transplant in sickle cell. And some of the recommendations were actually that for children who actually have need a transplant and have a matched sibling donor, the ASH recommends to use a myeloablative chemotherapy, so to do a transplant with a high-dose chemotherapy, because the engraftment is good and the survival is over 90%. In adult patients with sickle cell, there was a recommendation, suggestion, not recommendation, to use a non-myeloablative condition, so like a very light dose of chemotherapy in a transplant, because of less toxicity and very good outcome. The reason for this was initially the data that the NIH group published over 10 years ago, in 2009, almost 14 years ago, where they developed a transplant program for adult patients with sickle cell without using any chemotherapy. We like to say a chemotherapy-free transplant because we also follow the same steps. But anyway, there was only immunosuppression therapy and no chemotherapy. And the patient actually, in the first-time patient, 9 of 10 were cured, no complication at all, no mortality, no graft-versus-host disease. And this happens, however, the problem of this is actually only 20% of patients end up having a matched donor in the family, because the probability to have a sibling who is actually completely matched with the patient is only 20-25%. So there's a lot of other patients who actually eventually would not have access to a transplant. The alternative to this is actually to use I mentioned before, a haploidentical donor, like a 50% compatible donor, where almost anybody in the family becomes a donor. This has been a significant change in sickle cell, because most of the patients actually with sickle cell in this country usually don't have a lot of siblings, usually have families that have a lot of half siblings, and don't have any matched unrelated donor in the registry, because they're mostly composed of Caucasian donors. To develop this trial, this is the trial we developed here with a haploidentical trial, where we utilized a very small dose of chemotherapy. It's still considered a non-myeloablative transplant, with small dose of cyclophosphamide, small dose of fludarabine, and a small dose of radiation, total body radiation, only 3 gray. And in this patient receiving an unrelated a haploidentical transplant. Now, I'm not going to spend time on the results. I could spend a whole hour on this, but we reported our results both in the sibling transplant, where we showed 83%. This is actually the work of all the sickle cell team here at UIC. I want to mention in this Dr. Gurduk and Dr. Saraf in particular as great leaders in these efforts with me in transplanting these patients. But also we developed a strategy to do a haplotransplant. We modify the protocol that the NIH has developed, and we actually we published the results with 75% of patients being cured with a transplant using an incompatible donor, like a half compatible donor. The results are comparable to others. Actually, I'm not going to go into these details. Johns Hopkins, actually the one that actually started the first time this type of haploidentical transplant, which is using a post-transplant immunosuppression with cyclophosphamide, more recently increased the dose of radiation in their study. And by doing more radiation to the patient, they achieved a 100% engraftment in this patient, although they started seeing some graft-versus-host disease because the donor cells were all engrafted. So, but very successful in sickle cell, and also a few patients with thalassemia. So, non-myeloablative transplant or haplotransplant is a valid option for adult patients with advanced sickle cell, with over 70% cure rate, and could be even more than 70%. Based on the high rate of success, the transplant is also cost-effective. In a perspective, we also looked at the cost-effectiveness of transplant, which I didn't show you, but it becomes a cost-effective because the major cost of the transplant happens within the first year, and then the patient don't go to the hospital anymore. There are no pre-crisis anymore, and so this actually long-term becomes a valid option. Now, I've shown you 2 different options: the gene therapy and the transplant, and so pros and cons of both. I think I wanted to summarize to finish up with my presentation here. What's the best curative therapy for sickle cell? I think that both of the 2 options are very good, are curative. The allotransplant that I just showed you from a matched sibling donor is actually recommended, is the option number 1. They are the best results so far, but the donor is available only 20-25% of the cases. It requires post-transplant immunosuppression for at least a year with some possible infectious complications. There is a risk, although we have not seen a lot of this in using non-myeloablative regimen chemotherapy, there's a risk of graft-versus-host disease. Again, it's limited, but it's there, and it's part of the allogeneic transplant. And the data that we have so far with haploidentical transplant, which is available in a majority of the patients, is very good, but not as good as a match-related donor transplant. So on the other hand, though, a gene therapy or gene editing strategy, it's still experimental. I want to underline this. We don't have yet enough data. We have 20 years of history of transplant data. We don't have yet, we don't have a lot of long-term results in this therapy. But the data, the preliminary results that have been published are extremely encouraging, extremely positive. There's no donor required, so anybody is a candidate for a gene editing gene therapy strategy. There's no we're not worried about rejection or graft-versus-host disease because there's no donor. It's only patient cells, autologous transplant. There's a question mark on the possible risk of secondary cancer if using viral vectors. I think this has not yet been completely determined. And so far, the only one thing that to me is a little bit concerning is that patients are still receiving myeloablative chemotherapy as opposed to a very light chemotherapy in the transplant setting for adult patients. I have to say, though, that the initial data with myeloablative chemotherapy in this setting have not shown major complication in these sickle cell adult patients. As I said before, lack of long-term outcome data is another issue that we don't know if the results will last for 20 years or more. There's a question that added at the bottom of this, which actually applies to both these strategies. Affordability. The cost of these procedures is super, super high. We know that a transplant the transplant is covered by most, actually all of the insurances, Medicaid, Medicare. It's an expensive procedure. We don't know yet gene therapy and gene editing, what the cost will be. We expect FDA approval very soon, but we don't know how many patients will be able to afford it or their insurance will cover for it, will pay for it. So the pros and cons, I think, are mostly on availability of the procedures, on the availability of a donor in matched sibling. There's not yet a study comparing haploidentical transplant, which is available to a lot of patients, with gene editing. And that will be probably 10 years from now, this will be the topic of a discussion. By then, we will have enough data to say, okay, is autologous haplotransplant easy because everybody can have it? You don't need a donor. You don't need a follow-up with immunosuppression. You're just after a month in the hospital, you're done. Versus having a transplant setting where you have a transplant-related risk, even if minimal, for a much longer time. So I think the question is which one is better is not answered and will not be answered for a long time. But I think it's very good to have options open and to have people talking and knowing more about these things. So with this, I want to conclude my talk, and I'd be very happy to have your answers to answer your questions, if there's any. Thank you.
Thank you, Dr. Rondelli. We do have 2 questions in the chat Q&A. One question says, after stem cell transplantation, what is the patient identified as, SS, AS, or AA, and why would there be differences?
So it's a question actually requires a little bit of background. So depending on the type of transplant, when we in our experience we do a reduced intensity transplant or a non-myeloablative transplant, our patients actually after the transplant have a 50% average donor hemoglobin, and the donor can be completely normal or can be a sickle cell trait. If the patient has a 50% trait or normal hemoglobin, we know that clinically there will not be any sickle cell episode after that. Actually, it's been tested and was shown that actually even 20% of normal hemoglobin or hemoglobin from a sickle cell trait is enough to prevent sickle cell crisis. The question we had at the beginning is, whether this is going to change over the time. We stopped the immunosuppression about a year after transplant in patients who actually have at least 50% donor cells, and they do well. They don't really relapse. They don't have the sickle cell doesn't come back. So there's some sickle cell hemoglobin there, but it doesn't cause any problem. When we do a higher dose of treatment, like for example, in the incompatible donor cells, in the haploidentical transplant, where there's a little bit more chemotherapy, most of the patient become 100% donor. So the hemoglobin in the patient is over 90% or 100% from the donor. So there's almost no sickle cell there anymore. But again, the results are that there's no pain crisis, no others. More than 80% of patients no symptoms.
I know we're above we are past the time, but one more question. Michelle would like you to clarify transplant donor alternatives for patients with a sibling that is 50% compatible versus a sibling that is 100% compatible.
Yes. So a sibling that is 50% compatible could be a sibling from same parents, could be a half sibling, but 50% compatible could also be mom and dad, or their own children, or a cousin or an aunt. So these are only 50% compatible, and the transplant can be done because we learn how to do that by adding more immunosuppression right after, on day 3 and day 4 after the transplant. So 50% compatible is not only a sibling, could be also another member of the family. Compared to a full sibling, who is also, is not enough to be a full sibling. The full sibling also has to be 100% compatible. And this happens only in 25% of the cases of full siblings.
Thank you so much. We really appreciate your time giving this presentation. I am going to hand this over to Patricia.
Okay, our final speaker in this session is Dr. Joseph Colla. Dr. Colla is an associate professor in emergency medicine at UI Health. He received his medical degree from Case Western Reserve University School of Medicine and completed his residency at the University of Cincinnati. Dr. Colla has been working towards improving acute care and pain management for sickle cell patients. Thank you, Dr. Colla.
Do you want me to use my own computer?
It's up to you, Dr. Colla, if you prefer to share your screen or if you want me to share it.
Sure, I'll do this. Let's see if this works, as long as it's not giving the presenter view. Although, I mean, start. Are you guys seeing presenter slides or?
We see presenter view. You can swap it above that says swap display. If you go up, you see that? Click on that arrow, those 2 arrows.
Those 2 arrows. Oh, I see it. It's blocked behind my finger. Remove this and then swap displays. That makes that easier. That used to be a much bigger problem. Okay, so can I go ahead and get started?
Yes, please. Thank you.
So I have really nothing to disclose. I have no conflict of interest. There's no financial relationships. Basically, after a brief introduction, I'm going to talk about how, we treat vaso-occlusive crisis in the emergency department. And then I'm going to touch a little bit about my experience with individualized pain plans at UIC. So first, brief introduction. When preparing for this talk, I started with the NHL-BI guidelines and most recent ASH guidelines on treating acute pain. I then pulled up papers on specific subjects, and then I tried to gear this towards providers that aren't at a sickle cell center. But it's also helpful for those at sickle cell center, and I think it's a good way of communicating to my sickle cell colleagues, both patients and providers, kind of a little window into my world as an ER doc. This segment of a talk that was given at the AAM, it was well received by ER docs who wanted to learn more about treating sickle cell. So in many ways, the relationship between the sickle cell patient and the ER provider is a perfect storm and really a setup for failure. First, we talked about the poor transition from childhood to adult. The experience as a baby, as a child, is much different than the experience that sickle cell patients experience once they become a teenager, where they're met with more bias, disrespect, and suspicion. Patients, from a patient perspective, that causes them to put off their visits to the ER until they're in a lot of pain, which makes them makes it hard to get histories from. On top of that, there are concerns about missing school, some cognitive impairment on some patients from mini strokes and things like that. On the provider side, we often are dealing with on a daily basis, drunks and meth heads and violent patients, where it's the most common field to be attacked by a patient. It's a stressful environment. It's highly litigious. And on top of that, you have the opioid crisis, which, a lot of the ED docs, rightfully so, bear the blame for. And so there's this big movement to, reduce opioid use. Of note, it is important to state that, among this opioid crisis, really opioid use in sickle cell patients did not go up, and there are very few deaths from opioid overdose in the sickle cell population. I think it's like 10 per year, less than 0.7% of all deaths. With regard to vaso-occlusive crisis, I always, both ED experts and sickle cell experts understand that reported pain is the gold standard of pain. There's no lab value to determine how much pain a patient is experiencing. It's not vital signs. It's not how the patient appears. That last point is sometimes hard for ER docs to comprehend. If you can imagine a patient that does not have sickle cell comes into the ER and is having an appendicitis and playing Candy Crush, it would be off-putting for ED docs. They don't understand that from an early age. Patients are taught to distract with games on their phone and or deal with pain a lot differently. Some would say better than non-sickle cell patients. I try to explain this concept to my residents by saying that, there are really two disease processes going on with sickle cell. There's the hemolysis and the vaso-occlusion. And patients that are more on the hemolysis side, although there's a large overlap, they may have very low hemoglobins and they'll have leg ulcers, things like that, where the vaso-occlusion will not necessarily lower your hemoglobin. It's, more of the patients that we'll see in the ER with the, strokes and acute chest. When assessing a patient in pain crisis, it's important to note that the vaso-occlusion is a diagnostic exclusion. Granted, the majority of pain will be due to vaso-occlusion, but when there's you have to consider the potential that, especially if the pain is different or new, that pain in new locations or different areas could be the signs of something else. For example, a headache may be the sign of an early stroke, and abdominal pain might be ileus from opioid use or gallbladder disease. Bone and joint issues might be osteomyelitis and septic joints. That being said, I always recommend to my residents and students that, we try to get the pain under control before we get that really detailed H&P, even though I'm a big fan of that, getting a good H&P. So the theme of treating sickle cell patients in the ER is, parenteral medicine and early. This comes from a lot from the day hospital that Dr. Savings talked about, and some of the other docs about. Is generally most organizations recommend that we try to get the first dose within 60 minutes of registration, 30 minutes of triage. This is, these, by the way, these labels of strong, I forgot to mention, these are more my opinions for my reviews, and these are consistent. I would label it strong if it was more of a consistent recommendation, or if there's a lot of evidence, or if it was recommended by a major organization. And to also make sure you repeat these doses. It's really hard to accomplish that in the emergency department, as many of you know. There's also a strong recommendation for use of individual pain plans. Individual pain plans are strongly recommended by both the NHLBI and American Society of Hematology. It's due to address the well-documented variability in treatment for sickle cell, not just between institutions, but within institution, between different docs, between different days. It's well documented that patients will often get different treatment. It's better to have a standardized protocol. There isn't a lot of evidence on this. There is one randomized controlled trial that compared weight-based dosing versus individualized dosing and did show reduced hospital admission and better pain control. There is, ASH does make a comment that there is a small subset of patients that may not benefit from this. These are more of the high utilizers that may be experiencing more chronic pain or hyperalgesia. But we don't really have a good solution for this small subset. I'll get a little bit more into that in our experiences at UIC. One tip I give the ER docs is that if they don't have an individualized pain plan, then it's a good way to decide on the first dose is to convert all of the extra pain medicine patients are taking, not the long-acting morphine that they may be on for chronic pain, and convert it to morphine equivalents. This is a recommendation that doesn't come from me. It comes from several papers I read. And to convert that to morphine equivalents as your first dose. For example, if a patient normally takes morphine 30 milligrams twice daily, but over the past couple of days, they've taken 10, like 10 milligram Norco, you convert that to 30 milligrams oral morphine or 10 milligrams IV morphine. That's a good starting dose. In the ER, I always stress the fact that fever changes everything. This is also based on obviously the recommendations. Generally, it's 100% recommended that if a patient has a fever, and usually the cutoff is 101.3, that comes from NH-LBI, that you do obtain cultures. Usually a patient will get a chest x-ray. There'll be some shared decision making with that. And usually we do give antibiotics even if there is a positive viral test. Usually that is the case with more of the pediatric patients. Will definitely give a dose of antibiotics. And that's because, a lot of these patients are functionally asplenic and, there's a high instance of bacteremia, meningitis, and osteomyelitis. There's often questions about whether you can give NSAIDs, and in general, most recommendations say NSAIDs are okay, but just be mindful that patients have, a lot of patients have subclinical nephropathy, and that creatinine is unreliable. A lot of the type, as opposed to like diabetics and high blood pressure patients, creatinine does not usually always correspond to how advanced the nephropathy is. NH-LBI recommends just a small bump to consider maybe the start of acute kidney injury. Usually, if a patient is coming repeatedly, I try to avoid NSAIDs so that they're not getting a dose often. And I usually don't give the first dose of NSAIDs, usually Toradol, until I check their creatinine against their prior. When I was in training, oxygen was considered a treatment for sickle cell. That has kind of fallen away. In fact, in a lot of things, heart disease, stroke, we have avoided just empiric treating oxygen for patients in general. Specifically for sickle cell, it's thought to be a immunosuppressive. It is a treatment for hypoxia. So if they're actually hypoxic, we do treat them, or if they seem to be in the 92-95% oxygen saturation and having increased work of breathing or sensation of shortness of breath, we usually do start it, but it's not a per se treatment for sickle cell. So a lot of ED docs are interested in ketamine. I had to put this in the talk because of the obsession and stress we have about the opioid crisis. I often stress to the to docs I'm talking that yes, there is some evidence that it helps, but usually it's not recommended to be a monotherapy. In other words, it's not supposed to be a replacement for opioids. It's more of an adjunct for refractory or refractory pain. There is one randomized control study that did it head-to-head with morphine, and yes, the pain was about adequate, but the side effect profile was less desirable, and it was in children as well. So it's something to consider. We don't use it a lot at UIC because once you start a drip at UIC, if the patient is going to be admitted, it requires taking up of a bed of a ICU often, or a step down, and we're often short beds. So IV fluids is kind of controversial in general in ER. In the ER world, this is kind of the idea of just giving empiric crystalloid, meaning normal saline or lactated ringers, in a euvolemic patient has been frowned upon. There's not a whole lot of evidence saying it's harmful. A lot of this comes from the trends we are having with ARDS and critical care, and plus there's a few pediatric studies that shows that it increases the length of stay in the ED. There are a lot of experts, although there's not good evidence on this, that recommend half normal saline if you're treating a euvolemic patient as a therapy, but this is mainly based off of more like in vitro data, not like actual human data. But ASH kind of stays out of this and says no official recommendation. I know some patients swear by fluids, and I'm not opposed to do it in those cases, but it's usually shared decision making. Other adjunct treatments that are important, antihistamines. A lot of patients become itchy with pain control. It is recommended both by ASH and NHLBI to give antihistamines orally, not IV, because we're already concerned about sedation and such, and the benefits really aren't much better giving it IV where there's potential harm. Local heat, we use this in the emergency department. Often our sickle cell patients will break open the heat packs and give that to them, especially if asked, but sometimes we offer those. We also do lidoderm patches. Distraction, we talked about that, patients do that. And one of the things that probably get under stressed, I feel like even at UIC, is the use of incentive spirometry. The evidence is, for sickle cell evidence, it's pretty good that it could reduce acute chest. Often I will remind the admitting doc to go ahead and put an order on that, or I'll just put in an order myself if the patient's being admitted. Just a word about acute anemia and sickle cell. Almost all patients that come in the ER get a CBC and retic count, so it's not really a recommendation. Generally, we get concerned when the hemoglobin is dropped less than 2 grams. That doesn't necessarily mean we're transfusing, but we'll expand the workup to look for hemolysis labs, just in case it's a, aplastic anemia. And some hemoglobin SC and S beta thal plus, they actually could get sequestration theoretically. I've never seen it in an adult. I've only seen it in a child. But theoretically, we work that up. The other thing I tell my residents is to also make sure you ask this typical stuff you ask for non-sickle cell patients with regard to bleeding, like heavy menses, any blood per rectum, melena, things like that. I have been surprised to see that there was at least one patient I can recall where I asked that, and the patient was actually having a GI bleed as well, which may have contributed. And of course, the assumption was on my part up until that point that it was from hemolysis, but generally it usually is from hemolysis. So the summary of vasocclusion, and we'll get to my experience with IPPs. Generally, patients' reported pain is the gold standard. Vasocclusion is a diagnosis of exclusion, even though it is the most common cause of the pain. We want to get opioids fast and repeat often. Use IPPs when available if your institution has them. Ketamine is an adjunct, but not a replacement for opioids. And if there's a fever, you have to take it serious and get cultures, usually antibiotics, usually chest x-ray as well, and get incentive spirometry on early. So the next part of my talk is, and it looks like I have enough time for it, which is good, is the use of individualized pain plans at UIC. A lot of our experience from individualized pain plans came from the ALIGN study, which was one of the big studies that came up from the Sickle Cell Disease Implementation Consortium, which was a multi-million-dollar NIH grant, where we broke down that funding into 3 different studies. One of them was regarding the use of pain plans to improve care from the provider and patient perspective. The needs assessment, one of the reasons why we went forward with the ALIGN study was the needs assessment showed that across the board on these patient populations at these institutions, that generally 70% of patients admitted needing to use the ED. However, only 40% were satisfied. Many patients put off going to the ED because of bad experiences, and the number one bad experience was that they felt disrespected. From that, using stakeholder involvement, we came up with the strategy to develop IPPs for a select group of patients. And the way it kind of went down at UIC was that the patients were enrolled. The doc looked at prior use of opioids in the past. They came up with a plan specific to the patient. The patient had to sign off for it, and then had to get trained on both how to access it themselves. Also, were given like talking points when they went to the emergency department. We're given a little wallet card with the IPP on it. And then during an ED visit, the idea was that they would show their phone or notify the provider. and the provider could look it up in the medical record as well. I don't want to get too much into the enrollment here, but basically the patient, I'm trying to find my arrow, but I guess the patient had, it was a very select group of patients. The patient had to have both an ED visits within 3 months and have seen a sickle cell specialist within 12 months. So we made a list of all these patients, and then we invited them to a baseline visit, and we got their baseline perspective on going to the ER and use and pain control and all that. And then the IPP was reviewed by the provider and the patient, and then we just waited for them to have their next visit. There were several hiccups along the way. One of it was, despite our attempt to work, we were in the process of changing electronic medical records. Despite our attempts, the providers repeatedly had difficulty finding the IPPs. It was a constant effort on our part to remind them where it was. We did a horrible job involving ED nursing. That comes from actually the central level down to our institute, where it was kind of optional to to do these programs and talks with the nurses. Instead, we notified them about that in more of like a broad sense. And so a lot of patients would show up early on in the ED and be ignored about this IPP because people simply did not remember or did not know about that. And then there's a small amount of patients that just forgot to or did not show their IPP. Like I would go up to them, I'm like, did you mention that? And they're like, oh yeah. And so we had to remind them to right away, mention that. There's an issue with an IV access. We had a lot of patients that have poor IV access that we thought we were ahead of. We wrote in the IPPs, we got special permission to write an alternative with oral meds because we knew we had boarding issues and stuff as COVID was thawing. But even that was an issue because then the issue came, like we've always had a policy where we can give a few Norco and send somebody back to the waiting room. But there's this issue when we were ordering like 4 and 8 of Dilaudid orally, whether that was okay with our policy. So we had to again have a big meeting with nursing to fix that. And of course, COVID-19 really affected the flow of the emergency department. There were a lot of benefits from the IPPs. We don't have all the data back. We don't have much of the data actually back from all the 7 studies, but within our study, there was a clear patient satisfaction improvement. ED docs did like using it and intend to use them more. The ED nurses found it helpful. And generally everybody felt that it helped reduce time to dispo. We don't have information whether it had any effect on admissions yet. This is just some of the data here is that generally this is a scale out of 5 patient satisfaction and went from 3.4 to 4. But if you look at the more lower utilizers, and that's not necessarily absolutely low, but less than 5 visits per year, the satisfaction went way up as opposed a little less so than the higher utilizers. In general, no surprise that the satisfaction corresponded to how well the pain was controlled. If you ignore the different colors on this slide, you can see that generally the time to first dose, the patients that received their first medicine earlier had higher satisfaction. Providers were more likely agreed after the visit that they wanted to use it again. In fact, many said that they want to use it all the time or most of the time. This was not this chart here was not an actual study question. It was just me sending out, a survey a non-scientific survey to the nurses. And full disclosure, however, 19 nurses responded and the majority did say that they found the IPPs helpful. So where are we at now? I know I'm running out of time. Is that every step of the way now as we go along, the ED nurses have been involved. In fact, there's more ED nurse engagement than I'd say physician engagement at this point. We did make the IPPs more accessible and findable using the flags in Epic. And I'm now able to initiate the pain plan and design it from the ED. We realized that we had, we don't have a full-time counselor. We do have people attending to these IPPs, but we don't have somebody that's their job, which we really need. But to kind of speed things up, when I know a patient, I know what they get. I talk to them right then and there, and then I send the information to their doctor. And we've created several IPPs that way. Future challenges is obviously maintaining momentum with limited resources. The issue of ultra high utilizers, we realize we need a more comprehensive approach. Dr. Njoku, myself, and several others are getting together on a weekly basis to go on to talk about how we can help on a more broader sense with social issues and stuff with the half a dozen patients that are there, pretty much every day, to kind of help them get more long-term care so they don't have to spend all their time in the ER. And there still isn't standardization across the ED and the acute care center. So in summary, there you go, my summary slides. When you're doing IPPs, involve all the stakeholders, patients like it, providers like it. It should be accessible. That is a challenge. It may affect time to dispo. And there are some challenges in the future. So any questions?
I do not see any question in the chat.
This is Louis. That was a great talk. Thank you very much. And I appreciate fast talking. It was interesting to hear that you want to have a full-time coordinator. Would that be a nurse or a doc, or who would be such a coordinator?
We started pursuing it, but then because there's a lot of challenges, it's a hospital position. You got to create a position. You got to get buy-in. We were moving along that way. We're buying interest, and we decided that as the study was ending, some of the study coordinators were super talented, like Judith and such, could take control of that along with us, and maybe we can make like a team effort. But then we all get sidetracked. I mean, Judith is doing 100 things for some research and such, and I'm involved in a lot of different other research and endeavors. And so long term, yeah, I think that it would be really nice if we can convince the UIC to have someone at least for a few years to get these IPPs done, and we can move at a faster rate. Yes.
Oh, thank you so much, Dr. Colla. We really appreciate it. Now we have about 3 minutes for break time. We will be meeting back here at 2:10. Thank you so much. So welcome everyone back to the next session 3, Building Community Relations and Partnerships. I will turn this over to Miss Bridget Reynolds. to introduce the next team and panel.
Afternoon. Okay, we're gonna have a little fun here because we had a lot of fun doing this this skit, and but that's coming next. But first, I want to introduce to you the person who's going to be doing this panel discussion, which is a doctor PI who is relatively new to ISAC. She's a very affable person. We are so happy to have her as part of our team. She's easy to get along with, and she's creative and thoughtful. She did her medical education at the Chicago College of Osteopathic Medicine in 2012. She did her residency in internal medicine at Franciscan St. James in 2012 to 2015, and her fellowship in hematology oncology at Franciscan in 2018. And she is a member of the American Osteopathic Board of Internal Medicine. And quickly, Dr. Farooqui prides herself in holistic care. Her research focus includes expanded treatment options for sickle cell disease and increasing clinical trial options within her specialty. In addition to direct patient care and research, Dr. Farooqui also has a strong passion for medical education to help improve current gaps in healthcare. So without further ado, Dr. Farooqui.
Thank you so much, Bridget, for that introduction. I'm a little bit of all of what she said, but we can go ahead and start the scenario. I'm looking forward to this. I think this was the best session. We saved the best for the last. I really enjoyed working with everyone in coordinating this and putting it together. So this is going to be two different scenarios of patients with sickle cell disease that are based on real life experiences. And I would really like the audience to, tune out whatever it is that you're doing and focus on what exactly is going on in each scenario as we work through the complexities of caring for patients with sickle cell disease.
Scenario 1, case study. Here's a 28-year-old male with prior medical history of sickle cell disease. He enters the emergency room with left arm, leg, lower back pain, typical of a vaso-occlusive. He has cough, body aches, runny nose for 2 days.
Hi, Mr. McCullum. I'm your nurse. Tell me, how long have you had sickle cell? Your vitals look normal. You're dehydrated and in a lot of pain.
Patient is directed to the waiting room. The patient was assessed after 3 hours of waiting because his vital signs were normal, and then triaged and placed in the room.
Mr. McCullum, remove all your clothing. Put on your gown so it's open in the back.
May I have some warm blankets?
I'm sorry, we don't give out extra blankets. I have to ration them to last through our shifts.
After 30 minutes, the patient lab results come back. Creatinine levels are high. Emergency room resident reviews the patient's blood works and informs the patient.
My apologies. I think that something happened. Can you see the video, please? Someone tell me if they can.
We don't.
I don't see it.
Okay, let me stop sharing.
It was there briefly at the beginning before anything was playing, the still image.
Okay, let me share it again. Can you see it now?
There you go.
Yes.
Okay, so I'm going to start from the beginning.
Scenario 1, case study. Here's a 28-year-old male with prior medical history of sickle cell disease. He enters the emergency room with left arm, leg, lower back pain, typical of a vaso-occlusive. He has cough, body aches, runny nose for 2 days.
Hi, Mr. McCullum. I'm your nurse. Tell me, how long have you had sickle cell? Your vitals look normal. You're dehydrated and in a lot of pain.
Patient is directed to the waiting room. The patient was assessed after 3 hours of waiting because his vital signs were normal, and then triaged and placed in the room.
Mr. McCullum, remove all your clothing. Put on your gown so it's open in the back.
May I have some warm blankets?
I'm sorry, we don't give out extra blankets. I have to ration them to last through our shifts.
After 30 minutes, the patient lab results come back. Creatinine levels are high. Emergency room resident reviews the patient's blood works and informs the patient that his hemoglobin is 12, which he feels is not consistent with sickle cell disease. The patient x-rays show bilateral pulmonary infiltrates. The doctor enters the patient room.
According to your lab results, your hemoglobin is 12. Maybe you have sickle cell trait. Who told you you have sickle cell disease? Are you the only person in your family with the trait?
Can you call my sickle cell doctor, my hematologist, please?
Sure, I can do that, but before doing so, let me discuss this with you. Looks like there is something else going on. Looks like you are COVID-19 positive too. Your chest x-ray is positive for an infection.
Are you going to give me some pain medication? I usually take morphine.
The patient was given supportive therapy, including IV hydration and 30 milligrams of Toradol by IV once for pain control, despite the patient's request for morphine and despite the creatinine levels being high.
I will load up the second one. And I'll share it and let me know if you don't see it.
A 40-year-old patient has been hospitalized for 3 days. Pain has not been controlled.
Good morning, Mr. Smith. How are you doing?
I had a rough night. I was up all night in pain.
Well, your labs are improving. You look better than the first time I saw you.
But my pain isn't any better and my pain is not controlled.
I'm planning on discharging you today, and I'm switching you to oral pain meds, which you can manage at home. If you need to, you can come back.
A pill with this level of pain? I don't think oral meds is going to cut it.
But you've been here with IV meds for 3 days.
My pain varies. It can last more than 3 days.
Well, I don't see anything more I can do for you, and the hospital is not going to keep you. Sorry.
Patient was discharged, but came back within 24 hours.
All right, that was the end of our scenarios. I would like our panelists to unmute yourselves and get online. Next slide, please. So this is going to be a panel discussion on mindful practices around sickle cell disease. I have no disclosures. I would like to introduce our panelists. The first one is Dr. Insia Rizvi, who is my colleague taking care of adult sickle cell patients with me. She's been very passionate about her clinical activities at UI Health, and she has a very large fan base with the patients. So even though you saw her playing the mean doctor or the lost doctor role in the scenarios, in real life, she's just fantastic as a colleague and hopefully as a provider as well.
Thank you, Marwah.
Next on our panel, we have Dr. Larissa Verda. She is a program director out of Mount Sinai, and she works closely with our Isaac team to coordinate care and improve care for patients with sickle cell disease. Dr. Verda, I don't know a lot about you, so I will have you say a short introduction about yourself as well.
Thank you, Dr. Farooqui. Yes, I'm an internist. I'm a program director for IM residency program here at Sinai, and being blessed and honored to be part of this group for the last 2.5 years. And I'm happy to be here as a panelist, and thank you.
Thank you. So we really wanted to have this panel comprised of someone from academia, someone from the community setting. We wanted patients' voices be heard as well as nursing staff. So next is our very own Tara Gordon. She is part of our nursing department at the UI Health Sickle Cell Center, and without her, literally, I don't think I could have survived at UIC. So Tara, I will let you go ahead and introduce yourself. I know Tara has been here a very long time, and she's been a champion for sickle cell disease. Tara, you might be on mute. All right, perhaps there's some technical difficulties. We'll come back to Tara. Last but not least, really the brains and the woman power behind a lot of this summit today, I would like to introduce Ms. Dorinda Lawrence-Sims. Dorinda, if you can please go ahead and introduce yourself. You know, you've really been my go-to person for everything regarding, you know, just my research, my questions that I have, and it's always a pleasure working with yourself and the rest of the community advisory board. So if you can share just a little bit about yourself, and we'll jump into some discussion.
Oh my goodness. Thank you so much. My name is Dorinda Lawrence-Sims, and I am a sickle cell patient. I am also an advocate, and I'm also a representative of a community-based organization. I work in the community for on behalf of sickle cell disease. And as you said before, I couldn't do it. I mean, I've done so much with the summit, but like I said, we are part of a team, and teamwork makes the dream work. So let's go ahead and move forward with the scenarios.
All right. Beverly, do you mind putting up the slides? So as we delve in, I wanted to, present to the panelists as you guys listened to the various scenarios, just your thoughts about, each one. And then as we go through, we'll hit some important points. So we really wanted to put together this panel to see how would be the best way to approach caring for individuals with sickle cell disease, which is a very, very complex disease. Next slide. I wanted somebody to comment on, I know we talked about this a lot already, just a brief comment on for some of the new audience that might be joining in on what the different subtypes of hemoglobinopathies are as far as sickle cell disease goes, and how do the hemoglobin levels vary, because there was a comment in one of the scenarios, the first scenario, where the patient had pretty much normal labs. So how do we address this, and how do we reconcile between disease as well as, you know, some other conditions?
Sure, Marwah. I think I can throw some light on this topic. I know we've discussed this during, like, in the earlier sessions about this, but I will just try to go over some important points here. So sickle cell trait is not same as sickle cell disease. It is a benign asymptomatic carrier condition, and the patients who have sickle cell trait, they are generally asymptomatic. And there is basically, the pathology is that there is a single mutation in one of the alleles, and resulting in the blood that they carry has tendency to work absolutely normal under normal conditions. However, there are few situations where these patients can run into trouble, by which I mean, very less frequently what would happen, they can develop dehydration because their kidney loses the ability to concentrate urine. With that being said, another issue that these patients, or this population, I would say, can run into, they can develop a rare renal medullary cancer. Generally, if you talk about thrombosis, yes, some studies have shown they might have higher chances of developing DVT and PEs. Along with that, the problem sometimes is with the diagnoses that these patients, these individuals, they have normal hemoglobin. And as compared to our sickle cell disease patients. Now, and their life expectancy is, since they do not have the disease, their life expectancy is very similar to the individuals without sickle cell disease. Moving on to the different types of sickle cell disease, as we've discussed that in the previous lectures too, that depending on the patient's genotype, some patients might have more severe disease as compared to the other. Majority of the time, patients who have hemoglobin SS disease and hemoglobin S beta not sickle cell disease, those are the ones who would develop more frequent and more severe complications, as compared to the ones who have hemoglobin SC disease or hemoglobin S beta plus disease. In addition to that, again, as we know, there is some phenotypic variance too, where I've seen so many patients who have hemoglobin SC disease developing more frequent and more severe painful crises as compared to hemoglobin SS patients. If we talk about the baseline hemoglobin levels, so in general, patients who have hemoglobin SS disease, their hemoglobin usually ranges around between 6 to 9. And individuals who have hemoglobin S beta not, their hemoglobin can be somewhere between 7 to 9, whereas patients with hemoglobin SC disease can have hemoglobin between 9 to 14, and hemoglobin S beta plus can have hemoglobin between 9 to 12, which we definitely saw in this scenario where the doctor was a little bit confused about maybe the patient has trait just because the hemoglobin was 12.
Thank you for that detailed explanation, Dr. Rizvi. Next slide, please. So I just wanted to, get the panel's opinion on these two scenarios. How do you reconcile between the patient saying that, hey, I'm in pain, and the physician pretty much either trying to discharge the patient or saying, this is all I can do for you? In the various settings, whether in the nursing setting or, in the community setting, Dr. Verda, Dr. Rizvi, and Dorinda, if you guys don't mind just commenting on how do you reconcile between that disconnect?
Go ahead, Dr. Rizvi.
I don't think there is a disconnect, right? So we as a physicians, we believe our patients, and pain is very complex, has very complex mechanism involving not only kind of physical pain, there is nociceptive pain, there is something that comes as well with emotional pain and not just physical, right? That's why we have to take a look at the patient as whole. And when patient comes with vaso-occlusive crisis, many times you ask them, they say it's going to be 12 out of 10, right? And you believe them. The first thing you have to do, you want to relieve this pain as soon as possible. And I think just like Dr. Colla gave an excellent presentation and Dr. Shu on as early as possible pain management is a must, is a first step that you have to address, same as we give aspirin to patients with chest pain in non-sickle cell patients. Same, we should address a pain in sickle cell disease patient, because if not, that's gonna increase the number of complications, prolonged hospitalization, etc. So the best thing, you establish kind of relationship with the patient by believing them, being on their side, addressing their issues as soon as possible. I think an inpatient is a little bit different, and I don't know if Dr. Rizvi, would you like to comment on that? And as we know, non-steroidal anti-inflammatory medications in patients who have underlying kidney disease or present especially with acute kidney injury, which sometimes we cannot distinguish, right? Is it acute or chronic? We should avoid this. So the better would be perhaps Dilaudid would be, hydromorphone would be the first choice medication in those patients.
Thank you.
And plus,
Dr. Rizvi, would you like to comment on, just inpatient pain management, and how would you, in terms of discharging patients, length of stay and things like that, how do you reconcile between those?
So basically, what my approach is to the patient who comes in with vaso-occlusive episode, I think the first thing is to investigate the pain properly. That is the first and the foremost thing that we should do, because many times these patients can have pain, but it's not related to their vaso-occlusive episode, and there's some other underlying etiology going on. So our main guide is basically the patient. We have to listen what they're saying. You should always definitely, one of the most important questions to ask for is this typical of your pain episode? And they would tell you that they feel like, yes, it is typical of their pain episode, like their location, intensity, and depending on that, we decide what pain regimen we should go for. Again, it's just basically kind of like the management is just kind of like just what Dr. Colla mentioned too earlier. If we have individualized pain plan, then that's the perfect case scenario, because then we would be able to know what medication works most effectively for them and right away. Now, going back to, I think it's very important to mention here that when we're administering individualized pain plan, it's important, and it's part of the ASH guidelines, to administer the pain medicines right away, and the recommendations are within 30 minutes of their triage. And then depending on how the patient is doing, you should reassess them every 15-30 minutes until and unless they start saying, yes, their pain is getting better. And the tapering comes all the way in the end of their management, where when you see like the patient is getting better on day-to-day basis, that's when you decide if we should start going down and taper down. And then in addition to that, I think there are other adjuncts too that definitely play a very good role other than the opioids, like using heat packs, or if the pain is very refractory to the usual opioid doses, then we can definitely, there are other options to consider, like ketamine, lidocaine, NSAIDs. To be very specific, the recommendations regarding NSAIDs are, ASH does recommend if you really have to do NSAIDs, it should be of shorter duration. And definitely we should, before deciding on if we want to go that route, you should definitely see if the patient doesn't have any underlying renal issues, if they have any cardiovascular problems, if they have a history of peptic ulcer disease or not, or if they are on any therapeutic anticoagulation. So that's when I think you should stay away from NSAIDs. Same goes with, again, as I already mentioned, if opioids aren't working, then we do have an option of ketamine. And I think Dr. Colla already kind of like explained all that.
Ms. Sims, from a patient perspective, can you comment on, the scenarios and your experience with the healthcare system?
So for the scenario one, where the patient was coming into the ER in pain. So, okay, so we have you guys who are from UI Health and those who work with the affiliates of UI Health. You guys pretty much have training, and you guys are experts to us to care for patients who have sickle cell disease. But what about the person or the hospital or medical facility that a person goes into that's not a specialty clinic like UI Health, and they go into the emergency room and they are trying to assess the patient? How does it look? How do we get the physicians or the providers or the nurses to, to understand how to provide the care at another location, another medical location? That's what I'm trying to get. That's the question I have for you guys.
So how do you bridge the gap? That's what you're asking, right?
Yes. How are we bridging the gap between, yes,
non-sickle cell expertise centers and
yes.
Well, from a nursing perspective, I would say education, because if you're not regularly taking care of sickle cell patients and you don't know when they're presenting with signs and symptoms of a crisis, and you don't know best how to treat them, that's where I think the lacking care comes in. So I guess starting with educating staff on how to take care of sickle cell patients would be the. I'm sorry.
Is that Tara speaking?
that is Tara speaking, but I think they're having some technical difficulties with audio.
Okay. So yeah, I kind of wanted to know. So when you go to another facility, another medical facility, and and you're trying to you're coming in with the pain, and they're not, when you're telling them, you're trying to explain to them how they, I need this. This is what I'm usually taking, and they're not comfortable with giving you what Dr. Rizvi said about the type of pain medications, and then you're looking now like, what do I do? And then when the patient asks to call to call my hematologist or call my specialist, then where do we go with, because some people, when you go to the ER, Dr. Colla, of course, is different because he's at UI Health. And so when you're going to another ER, how does it look, for caring in another facility? Or how we get the other providers to understand how the care looks, for providing care in another hospital?
I think it's a great question, and I think there is no great answer to that. I think this summit is part of that plan, how to extend the care, right? To educate all healthcare professionals to see how to approach the patient, how to treat, how important it is. But I think, as well as a program director, and I understand it's important if I educate my residents so they go to their facility after graduating, they can spread the word. So I think it's important to start and educate at any point of time, and that's why there is a national strategies to go on, and that's why the first NIH grants started to with IPP plans, and that's why UIC kind of reach out to Mount Sinai, reach out to Lawndale, so we can bring more people on that project and spread the word.
Yes, and then I would definitely like to add, I totally agree with Dr. Verda. Plus, I think education, along with the educating the new residents, educating the new future doctors, I think it's also important I think it would have been beneficial if the patient had like an individualized pain plan card with them. If not card, then at least if we can somehow definitely save the pain plan in the EMR. So that can be of immense help too.
So is the IPP like you carry that with you, so you can take that to another hospital and they know what that means?
They know
Yeah,
where the IPP is in another hospital.
hopefully.
That's it, hopefully. That's the question, is hopefully. Go ahead.
I think that's the most important takeaway from this summit, just educating healthcare providers, educating patients, educating caregivers. I think that's where we just need to keep at it. And, that's where the progress will come. As you can see, sickle cell is a multi-organ, multi-specialty, multidisciplinary disease. So we need to have all hands on deck to care for these individuals successfully.
Right. And then another thing was how, being able to, like you said, assess the patient, fully assess the patient, because not only was the patient dealing with just a sickle cell pain crisis, they were dealing with some other underlying conditions that they had, like it was COVID, some things like that. So you come in to the ER, and it's not just saying, oh, okay, this person may be having a sickle cell crisis. You have to examine the patient as a whole, because even though you have the disease, the whole patient needs to be examined, from weighing out all options of care besides just the sickle cell disease, because COVID, I think the patient had COVID as well. And so, you want to make sure that the patient is getting their overall exam, not just with your sickle cell, because we talk about that a lot amongst those in the group, that, we want to be treated for sickle cell disease or the pain crisis, but you're still a whole person and may have other things going on with you besides just sickle cell disease.
Definitely, I agree with that.
Yeah.
And can I speak about that part of the COVID?
Yes, Ms. Reynolds, I would appreciate your input.
Yeah, this is a skit that came from experiences. I compiled all of the experiences that I began with, the experiences that I had amongst living out away from the university or a healthcare center that specializes in treating sickle cell. You will experience these things, and a lot of people are in disbelief when you tell them or you try to address the type of things that you may experience on a regular basis. And they just, if you're at a sickle cell center, you may not know that these things are going on. The COVID issue, I had COVID, and I had chest syndrome before, and the doctor told me, well, if it's despite your chest syndrome, I don't want to give you any medication. And I was running around from there to another place, and they're not giving out COVID. And the demographic, you have African Americans are more affected by COVID, and then to have sickle cell and have a history of chest syndrome, and I was scrambling trying to find medication for the COVID. So those kinds of things, we, a lot of that's where that training comes in, and being able to have access to qualified practitioners in the outlying areas.
Exactly.
So I think here in this scenario, there was an issue where the patient wasn't given remdesivir, as well as wasn't given antibiotics, from what I remember we saw in the scenario. So I would definitely like to touch base on that. Patient who have COVID and have sickle cell disease, there is no harm in giving them remdesivir if they meet the criteria for the diagnosis or for the indications for remdesivir. That is, they're hypoxic to less than 90s, and their LFTs are not 5 times higher than the normal. So this patient should have benefited from remdesivir. Although it was a viral infection, definitely the patient would still get antibiotics because of the risk of superimposed bacterial infection. Other than remdesivir, if we're considering any other monoclonal antibodies or Paxlovid, again, essentially the threshold for those medication is even lower for sickle cell disease patient, just because they have splenic function impairment as well. So I think that was an issue in this scenario that should be addressed.
Thank you for that, Dr. Rizvi. The last question that I'd like to put out to the panel is, oftentimes the frontline healthcare worker, whether it's the nurse practitioner, the physicians, is always the bad guy, but oftentimes you're having things from higher ups, whether it's insurance, whether it's healthcare administration, How do you reconcile between that and, caring for the patient appropriately, whether it's in an ER or an office setting or, at time of discharge? If you guys don't mind commenting on that, and we will wrap up.
Can you say the question again, please?
So oftentimes it's the frontline person that the patient is dealing with that gets blamed for, not having the appropriate discharge medications or getting discharged too fast, not being heard about the pain medication regimen and things like that. But sometimes it's coming from other sources such as insurance, hospital administrations. How do you reconcile between that disconnect?
So,
okay. Hi, it's Tara. I think this is working now. So I would say from a nursing standpoint, it's just basically when patients are calling, they're upset about they're not getting their medications on time or not being able to be seen in the clinic in the appropriate time frame. Basically, just first allow them to express their concerns, and then list. And then after they express their concerns, just communicate what's going on with. Communicate what's going on. Try to explain. Explain the situation to the patient so that they're in the loop of what's going on, and hopefully that can mitigate some of the stresses that they're experiencing.
So can I use a word? I want to use a word that I think, so I'm gonna say the word empathy. And when I say the word empathy, I don't mean just for the patient. I mean across the board. Okay, so I feel like, and maybe you won't understand what I'm saying. As a patient myself, I feel like what Tyra just said, like when you come, the nurses are doing their job and people are trying to care for you, it has to go on all sides. The patient has to be empathetic, but the doctor has to be comfortable with their, and then you need empathy from the nurses, from the staff. So empathy needs to go across the board with everyone, I want to say. And that means the patient as well. That means the nursing staff as well. That means the doctors as well. Because empathy, if you're caring for someone and you have no empathy toward what the person is going through, whether you're comfortable or not, with the type of meds they're requesting, I feel like you need to get some type of education or a superior who may be able to help you understand the condition or the situation, so that the person who's the patient is not suffering or not getting what they need, their needs met as well. But the patient has to also know that if a person's not comfortable, then you need to ask or request for someone who is comfortable with providing it. If you can't do it, okay, I'm sorry. Can you get the next person or superior who may be able to help me get what it is the patient needs?
Right. And I would say also that, there are situations where you do have to tell people if your hands are tied, but then what you need to do is take another step. And what a lot of times what we see is people are just telling them, what they cannot do and passing the buck. A lot of times in business and as a consumer, because patients are consumers, we don't want to know about what how your process operates. We just want to get our benefit out of it. And but as a patient and having had medical background, I usually try to find out what is happening and why it's happening. And then that gives you some kind of clue. But if you're the healthcare worker and you can't do something, you need to find a way to accommodate that person, that patient. It may not be your job, and sometimes you're going to have to step sideways and be that person who connects them to the appropriate person. A lot of times there may be an appropriate person, but they'll just leave it because it's not their job. So you have to be able to add value to your position and then go a little further and find out who can solve this problem. I'm usually talking to administration when when I deal with situations like this, because one, I don't like fisticuff, and the other thing too, I do like to collaborate and know that your patients do want to collaborate with you. And despite being in pain, you might be, your temper might be, you might be short-tempered if you're in a whole lot of pain. Yes. But be collaborative and offer that patient something, give them something, or someone who can solve that problem.
Exactly. So that's where, exactly, that's what I was saying, that you were, as Dorinda was saying, you do be empathetic, you listen to the patients. And then at that point, then you will explain what is, what is within your control to do. And then if there's something that can be addressed by you, you will go ahead and address it. But if it requires someone outside beyond for you to do, then yes, you would take those necessary steps, but still there is come a point where it's still beyond our control. And so we try to explain it to the patients and just to let them know where we are in the process of trying to.
And that's why I started saying empathy needs to go across the board. And that means the patient too. That means everyone should try to practice a little empathy. That means, even though there's a need, that we need to all still have a little empathy across the board.
The collaborative approach.
With the collaborative
Thank
approach.
you so much for that productive discussion. I believe our time is almost up. I do want to leave the audience with a few guidelines that are available for sickle cell disease management. Remember, these guidelines are nothing if we don't implement them. So definitely do refer to these guidelines when you're caring for individuals with sickle cell disease. And UI Health will be starting a monthly virtual education series as well to help healthcare providers learn more about the management of sickle cell disease. Last slide, and we will wrap it up. Thank you so much. So this is a slide. I don't know if you guys were able to read it. It was just a cartoon of a regular red blood cell and a sickle cell, where the regular red blood cell is asking you what the secret is for the wonderful waste, and it's the oxygen. I hope you guys appreciate that. All right, thank you.
It's really cute.
All right. Thank you all very much. We do a round of applause kind of thing here. I think this has been a fabulous day. Thank you all for staying online with us. I have just a few thank yous and credits and so forth. Beverly, can we roll a few more slides here?
Yes, I can. Give me a few minutes.
So I think we had a peak attendance of about 80 something. So thank you all for joining, and thank those who've stuck around through the end. This next slides are, let's see, coming. One is going to be about the UI Health Sickle Cell Center Patient Support Group that will start in about 3 hours. So the first one is today at 6 p.m. For more information, contact this group here, and that's going to be a monthly support group at UI Health for sickle cell patient support. Next slide. This is the inaugural meeting, by the way. At a statewide level, Sickle Cell Disease Association of Illinois has a monthly support group also that meets on the third Thursday of the month. So that was last week. Hybrid, so it could be Zoom, it could be in person. I understand sometimes there's snacks. I haven't been there myself, but advanced registrations requires you can get into the Zoom, and so there's not any kind of Zoom bombing kind of stuff. But that is Chicago and the state of Illinois, but there have been people who attend from Texas and Indiana and elsewhere. So you are not alone. If you can attend these, please go ahead. The contact website is there, sicklecelldisease-illinois.org, Sickle Cell Disease Association of Illinois. Next slide, please. Team Isaac, we want to thank all the members. This is a group that has been meeting practically weekly for about 6 years, thereabouts. So the fearless leader, Dr. Victor Gorduk, I'm in there, Dr. Insia Rizvi, Dr. Marwah Farooqui, Dr. Joseph Colla, Dr. Larissa Verda, Dr. Ananta Pandit, Dr. Eugenia Sanders, Dr. Kay Saving, representing several different institutions in collaboration called ISAC, Improving Sickle Cell Care for Adolescent Adults in the Chicagoland area. And we also definitely want to thank Taif Hassan, Erica Galvez, Ryan Cooper, Dennis McCullum, Judy Nosik, who is very patient in herding all of us together. Patricia Lasley, likewise very patient, and Nikki Bunker over at Peoria. Thank you, everybody. Next, please. The Community Advisory Board, you heard from the beginning. Here we're going to hear it throughout everything, was instrumental in planning the entire conference. Beverly Chukwudozie, Ryan Cooper, Maxine Jones, Bridget Reynolds, Dorinda Lawrence Sims, Patricia Lasley, Dennis McCullum, and again, Judy Nochik being the glue person, pulling everything together for the Community Advisory Board. This is a powerful community advisory board here. Next, please. And we thank you all for your participation. Part of the message here is that there's a lot going on in sickle cell, lots of progress. None of us could fit our talks into the time that was allotted because there's just so much going on. But at the same time, still lots of problems to solve, lots of things to implement. And so we appreciate everybody jumping in, rolling up your sleeves, and sharing in the work, which is becoming very fruitful, as well as recognized, where previously sickle cell was hardly recognized at all. And is there another slide? And this is the last few days of Sickle Cell Awareness Month. You saw that Peoria's bridge got lit up in red in recognition of Sickle Cell Awareness Month. Chicago had the Blue Cross Blue Shield headquarters building lit up with Cure Sickle Cell in the early part of September. If you have anything else you can get done in the next 2 days of September for sickle cell awareness, do it. Let us know what you did. And I think that concludes our session. Thank you all very much.
Great
Thank
job,
you all.
everyone.